much. On behalf of the entire steering committee and transdisciplinary team, it is my great pleasure to welcome you all to this first annual course of iHF, Improving Heart Function. Over the last year, we have worked hard to achieve this important milestone, that is building an educational platform to advancing innovation and collaboration in the management of heart failure patients. We are particularly proud to see participants joining us from all over the world, mostly from Europe, but as you can see, we have a significant representation from America and Asia. The diversity of our audience is one of the core principles of iHF, that improving outcomes in heart failure patients requires collaborations across specialties and across healthcare systems. Thank you all for being part of this first edition and of this initiative.
The iHF initiative was created as an innovative educational program with a clear goal: to promote comprehensive and patient-centered care for patients with heart failure. Heart failure is one of the most complex conditions we manage in cardiovascular medicine. Its treatment increasingly involves multiple therapeutic strategies, including pharmacological therapy, advanced imaging, interventional and surgical approaches. For this reason, iHF was designed as a transdisciplinary platform, bringing together cardiologists, surgeons, intensivists, electrophysiologists, imaging specialists, and many other professionals involved in the care of patients with heart failure. The aim is not only to share knowledge, but also to identify unmet needs in heart failure management and improve the integration between drug therapies and medical device strategies, ultimately to optimize patients' outcome. Education and sharing experiences are therefore at the core of this initiative.
Over the past year, through webinars, expert discussions, and clinical case resources, we have created a forum where specialists from various disciplines can exchange ideas and discuss real-world challenges in heart failure management. These activities have highlighted an important reality. The management of our heart failure patients requires continuous dialogue between specialties and continuous updating of knowledge as therapies and technologies evolve. The launch of the iHF annual course represents the next step in this journey. It provides a structured learning environment where expert and participant can explore complex clinical scenarios together and discuss how best to integrate new therapies into everyday practice.
This annual course has been designed as a digital-first educational program bringing together healthcare professionals involved in heart failure care from all around the world. The two-day program focuses strongly on practical, clinical, and decision-making with sessions built around real-world cases, interactive discussion, and importantly, multidisciplinary perspective. The objective is to bridge knowledge gaps and to facilitate meaningful dialogues between specialists involved in different aspects of cardiovascular care. On day one, the following session will take place. First, acute coronary syndrome with cardiogenic shock, how to challenge clinical setting in need of transdisciplinary management. The second one will be dedicated to precision pathway in patients with aortic stenosis awaiting TAVI. Then, the session will be focused on advances in the management of heart failure beyond the 4 pillars. And finally, mitral regurgitation, finding the right time for the right patient, how soon is now.
And on day 2, the following sessions will take place. Integrated care in aortic stenosis and HFrEF, from medical therapy to percutaneous intervention. Second, decisions at the edge, from drug escalation to CIED implantations in atypical HFrEF. Third, bringing intelligence to decongestion management. And fourth, but not least, PVCs in heart failure, what to do medically, what to ablate or leave alone. All the topics are discussed in the sessions are approached through a patient-centered and multidisciplinary perspective, bringing together the expertise from interventional cardiology, electrophysiology, heart failure specialists, cardiac surgery, and intensive care. These sessions are meant to be highly interactive. We very much value your questions and comments. Our ambition is simple: to help translate advances in science and technology into better decisions and better outcomes for our patients. This course will not only provide valuable knowledge, but also stimulate discussions, collaboration, and new ideas. Once again, thank you for joining us for this first edition of the iHF annual course. We wish you an inspiring and productive program.
What is the best strategy to treat patients with multivessel coronary artery disease and reduced ejection fraction remains an ongoing debate. The STITCH trial demonstrated that CABG provides a better survival rate than medical therapy alone, while in the REVIVE trial the same benefit was not observed with PCI. But what is the therapeutic potential of combining these two strategies together? Hybrid coronary vascularization, defined as the combination of minimally invasive LIMA to LAD bypass and the PCI for the treatment of non-LAD vessels, seems to be a valid alternative to conventional CABG for the treatment of multivessel coronary artery disease. However, its role in patients with reduced ejection fraction has not been investigated yet. In this retrospective study, we included patients with multivessel coronary artery disease and an ejection fraction below 50%, who were treated with either hybrid coronary vascularization or conventional CABG in the same center by the same surgical team. We performed a propensity score matching using baseline characteristics as covariates to balance the two populations. And we matched 50 patients in the hybrid group with 50 patients treated with CABG. The primary endpoint of the study was a composite of all-cause death, myocardial infarction, and any revascularization during the follow-up. After matching, baseline characteristics were comparable between the two groups. The mean age was 66 years old. The majority of patients were male, and about 1/3 had 3-vessel disease. The Euroscore 2 was overall low, with a tendency to be slightly higher in the hybrid group. Kaplan-Meier analysis showed comparable overall survival at 5 years follow-up between the two groups. And similarly, there was no difference in the primary composite outcome and in myocardial infarction. However, hybrid coronary vascularization was associated with a significantly higher incidence of repeat revascularization. Regarding early postoperative outcomes, we observed no significant differences between the two groups. So, in conclusion, in our cohort of patients with multivessel coronary artery disease and reduced ejection fraction, hybrid coronary vascularization provided similar mid-term survival compared with CABG, with comparable perioperative outcomes, but a higher need for repeat revascularization during the follow-up.
Hello, everyone. It's a real pleasure to be with you today, and welcome to the online Improving Heart Function 2026 course. This is a session which will discuss a very important topic, which is acute coronary syndrome with cardiogenic shock, the challenges of clinical settings in need for transdisciplinary management. And I'm very delighted to be here with you. My name is Hatem Soliman. I'm an intensivist in London in the UK. And I have with me a representative from the heart team and an example of a multidisciplinary collaboration. Very delighted to have my co-chair, Alex Mebaza from France. And we will have with us discussants. We have Owais Dar, a cardiologist from London in the UK. We have Marina Clément, a cardiac surgeon from France. And we have also with us Antoine from France. And we also have Ofer Amir from Israel. And we have with us also online Salvatore Brugaletta, a cardiologist from Spain. So we will start with this case, and I will hand over to Alex to start the case presentation.
Yeah, thank you so much. This session is going to be a very, very nice session. And let's first maybe describe the objectives. Is to discuss the optimal intensive care management of patients with acute coronary syndrome complicated with VSD, ventricular septal defect-related cardiogenic shock, to understand the indication, timing, and type of mechanical circulatory support systems, and you will see that here in the room we have really top experts, to apprise the most suitable interventional strategies, timing, percutaneous versus surgical, tailored to the individual patient's risk profile. And now it's my deep pleasure to introduce Salvatore Brugaletta, who is going to present his case in two phases. The first part will be describing the patient, how he discovered the patient, how he was introduced to the patient, and then we will have a discussion, and then we'll see the outcome later. Salvatore, it's your turn.
Thank you. First of all, I would like to thank you all for the kind invitation. So let me introduce our patient today, so that I prepared together with Dr. Velasquez. So these are my conflict of interest. So here we are discussing about a 58 years old male. So with cardiovascular risk factors are smoking, who was a little bit overweight, and dyslipidemia. And then he started so with atypical symptoms with some cervical pain, so since 5 days, which was followed by progressive exceptional dyspnea with some pain in the jaw. And for that reason, he went to visit his GP. So the GP performed this ECG, as you may see, with the ST elevation in the inferior leads. The patient was wheezing with some tachycardia. The blood pressure was good. And the GP called the ambulance, and the ambulance came to take the patient. Then they administered the aspirin, prasugrel, and fractionated heparin at this dose. And they brought the patient directly to the cath lab. So there were 90 minutes between the first medical contact and the arrival of the patient at the cath lab. Everything was done in a spoke center, so it was not done in my hospital. And here I can show you the coronary angiogram. So at the spoke center, here you see the left coronary artery, which was fine, so either the LAD or the circumflex. And then, as expected, moving to the right coronary artery, so we have this occlusion in the mid-distal portion of the artery. So the PCI was without any, anything difficult. So the lesion was crossed with a normal guide wire, and then so a stent was implanted, 3.519, which was then post-dilated, and this was actually the final results, which I must say that was quite good with a TIMI final 3. Anyhow, so the patient was still not doing good. So he had some persistent tachycardia, so he had some bilateral cracks. And then the doctor, so then inside the room, so this was done so immediately after the coronary angiogram in the cath lab. So they discovered a pansystolic murmur. So there was some gas analysis done, so with this result. And at some point, so immediately after the angiogram, So there was an echocardiogram done. Then you may see here some hypokinesia in the inferior wall with some aneurysmatic deformity. And then by putting the Doppler here, so it was quite clear that there was a ventricular septal defect in this mid-muscular septal portion. So, and now it's time to discussion, because this patient is in a Spock center, so he's still in the cath lab, and we have to say what we have to do.
Great. Thank you very much, Salvatore. Now it's a question to our panel. Do you have any questions to Salvatore?
Yeah, I wonder if I could ask Salvatore, what comorbidities does he have? What's his premorbid state? So we've got a gentleman with a late presentation MI who's been revascularized. I'd be interested to know what he was like normally before he had it.
Yes, as I said, so he had the same some cardiovascular risk factors, so some hypertension. He was, overweight, as you may expect, by a Spanish gentleman, but he didn't have, any major comorbidity. So he was also, I would say, relatively young, because he was 56 years old. So no, previous history, either from the cardiovascular point of view or, other territories.
Thank you. Yeah.
Thank you. And I have a question to Ofer. What do you think about the hemodynamics of this patient? Is he in cardiogenic shock? And how do you grade or classify the severity of the cardiogenic shock?
So, thank you for the question. Excellent presentation. The point is that the SKY classification is very easy, very practical, and you can get it very easily. One issue is that the SKY basically goes with congestion to hypotension to hypoperfusion, and this patient had normal blood pressure, although he was a little bit congested. So definitely he's not on A class, but he was on a B class, which is a beginning. One important point to remember is that while you can use the B for the beginning of a shock, it can also be a bridge to a more advanced shock, and that's usually what happens with the B. So you have to treat B class as a very transitional zone, and you should expect that the patient will not stay in B, as usually they are not, and deteriorates to higher classes.
Yeah, thank you very much. Just to stay on the SKY definition, in patients coming in your center, every patient who's hemodynamically unstable, would you immediately, the junior, etc., would they immediately put the patient on a SKY stage? And are you teaching those fellows to follow the SKY stage and then to react? How is the situation in your center?
Absolutely. And this is very important, Alex, because SKY is a continuation, and it's a continuum stages, and you have to be not only define the class when the patient is arriving, which is the basic part. I think what is more important is to follow the patient in the continuum of the SKY, and this is very helpful in both understanding that the patient deteriorates and also to dictate what you need to do, what you need to do next.
Yeah, I think it's important to mention that SKY is not only one picture and one time point, it's really an evolution. We are lucky to have a cardiac surgeon, but before asking her questions that are really crucial for the management of this patient, I would like really to remind everyone that the chat is open, and please, we start to have some questions already. Please put your questions on the chat, and the experts here will be very happy to answer your question. Dr. Marina Clément, you're a cardiac surgeon. I'm sure this case is of great interest for you. What are the recommendations of first intention for this ventricular septal defect? Is it surgery or no surgery? What is the answer?
First, we have to keep in mind that without surgery, the mortality is around 100%. So there is no alternative, I think. And the question is not really if, the question is more when. And as surgeons, we know that in front of this patient, when we operate very early, it can be a nightmare because we are sewing into butter, because we are operating on dying tissues. So we have to wait a little bit, as much as we can. at least 7 days to improve the quality of tissues and to improve, of course, the quality of the repair. But these patients are really unstable and it can be very quickly to degradation. So before to think to surgery, I think we have to think to stabilization of the patient with mechanical circulatory support.
Are there some, I'm talking also with people who are doing a lot of imaging, are there some parameters like imaging parameters or other parameters that will tell us without bothering the cardiac surgeon, it's time to go to surgery, the tissue is the right tissue, or it's really, we should recommend a minimum of time? What do you think?
Time will, fibrosis will come with time, and we could make an MRI on this patient, but in fact we don't do because all the devices around them.
Yeah, they're hemodynamically unstable with many.
We know that the time will bring fibrosis. No?
Absolutely.
Yeah.
Hatem, yeah. Well, I mean, what would you do with this patient in your center?
Well, I think
pray. I think praying is important, and having the best surgeons for sure.
Absolutely, being preemptive is very important. Planning and thinking, having high index of suspicion. Clinical assessment is so important to pick up these patients very early. Early referral to specialist centers is very crucial, and early identification of VSD, because as Marina mentioned, the mortality is 100% if the treatment is not done promptly. And then, of course, allowing time for the stabilization on mechanical support, depending on the severity of the clinical condition, and then intensive care management. And maybe asking Owais, what do you think about the role of revascularization in this patient?
Thanks, Adam. I think it's a good question. This is a late presentation MI. He's already had chest pain 5-6 days ago, and he's been fully revascularized. But you could argue the infarct has done its damage. He's already developed a serious complication. And there's, in my view, there's a clinical equipoise here in whether revascularizing is going to help. For me, the more important issue is early recognition, as you've said already, of the VSD and escalation, because he's at risk of significant shock and deterioration. But I don't know what you guys feel.
Same.
Yeah.
In fact, it's difficult because those patients during the week, we have weekend and nights.
Yeah.
And then we need, when the fellow are on call, we need to take time in the front of this patient that looks stable. I mean, this patient, we are going to see what would be the outcome in a minute. But the patient looks stable, lactate is 1.9. Then if you are a young fellow, you would say, I mean, the seniors are a little bit stressed, and I know exactly that this patient is going to do very well. In fact, we should take some time, and I think it's interesting, when we are rounding before the night call, we should really explain, no, the situation can worsen quickly, who we should call, and why, and what should we do. And how would you do it in your center?
Exactly as you said, Alex, is the recognition, explaining to your team that this is a serious situation, the patient could deteriorate, and having a plan in place that could mitigate any bad outcome. So that might be early escalation to ITU, inotropy, or other sort of short-term support. That would be my view.
Yeah. Alex, if I may comment, there were 3 red flags in this patient. First of all, in spite of having inferior wall MI, which usually goes with vagal tone, he was now in a high sympathetic tone, which is very unusual. Second, is he was in a late arrival, which increased the chances for complications, and this is important. And he was congested, at least clinically. So it was more than a simple kind of inferior wall MI, and that's it.
Yeah, you're totally right. But Amir, you agree that even your fellow, unfortunately, all our fellows, and we were fellow, sometimes they look on one parameter, and often it's systolic blood pressure, and they try to tell the whole story around systolic blood pressure. And then you're right, we need to spend time, as we said during the round, to say, be careful, oxygen saturation is not good. This patient is doing pulmonary congestion. This patient has a lactate of 1.9 because the right ventricle is still not suffering. But if we give a little bit of volume loading, we can make the liver sick and worse, and the lactate may increase. Then it's really a very important situation. Hatem, now I am your fellow. You don't know this, but I am your fellow. And I heard that during the round you told me, as Amir was saying, the patient is in fact looks good, but he's really not so well. And I heard that to define shock, I need cardiac output. Can you tell me how am I going to, because you know now the flow is going in all the directions, then can you a little bit elaborate and tell me how the blood is going inside the ventricles and how am I going to measure cardiac output? And I heard QP, QS, what does it mean?
Of course, thank you, Alex. I think here the role of bedside imaging and Doppler echocardiography is very vital because it can provide immediate information validated against the standard invasive hemodynamics with PA catheter. Doppler measurement of the shunt ratio, the QPQS, is very doable at the bedside by measuring the flow on the right side and dividing it by the flow on the left, and then you get the ratio, which determines the shunt ratio, which can quantify shunt in this situation. But it has some pitfalls. For example, in very large VSDs or bidirectional shunts, it becomes less reliable. And that's why for decision-making and for surgery, the role of FIC principle is really important to have reliable assessment of cardiac output.
And then I think the question is important because I don't know whether it will be the case in this patient, but often we like to put swan guns. And then you agree that there will be some disconnect. How, as a fellow, how am I going to interpret what I'm going to measure in the aorta and what I'm going to measure in the swan guns? Can you help me a little bit here? I know that Antoine is going to cover this later, but I think it's important that you start to teach us a little bit how we should interpret all this.
Of course. The issue with the thermodilution here is that the recirculation in the right heart from the left to right shunt can change the measurement and lead to unreliable assessment. And that's one of the reasons the pulmonary thermodilution is less useful in these situations. So we should use the Swan-Ganz data very carefully in patients with VSD because we can have overestimated measurement of cardiac output.
But let me be provocative. We did not say, you did not say we should not put a PAC catheter, we should put a Swan-Ganz, but some parameters are correct and some are incorrect. Can you help me there?
Absolutely, because it will help us obtaining the pulmonary vascular resistance, which is really important.
Should we expect in this patient pulmonary catheter wedge pressure to be high or low?
We are hoping, I mean the wedge will be very high obviously, but we are hoping the right heart is coping because it's one of the issues which can predict bad outcome. If the right heart is compromised and the pulmonary vascular resistance is very high. So all these numbers help a lot, but the SWAN is helpful to obtain the saturation, the oxygen saturation, which will be required for the FIC measurement of the shunt fraction and cardiac output.
Oxygen saturation of the pulmonary artery.
Yes.
Which give an idea on the general circulation.
Yes.
Then we need the pulmonary artery catheter.
We do.
But we should be careful on interpreting the cardiac output. Yes.
Can I just make a comment? Because it's the mixed venous saturation that's really important. Because you've got a VSD, there's basically oxygenated blood in the right ventricle. So the true mixed venous saturation is not the PA saturation. It's a combination of the IVC and SVC. So I think it's important that we sort of distinguish that in the setting of a VSD.
And in any case, we have to remember that it is overestimated. And probably the reality is much lower.
Yeah.
Wow, I think we're entering here. We see here that we are a room with top experts, and I would have loved to be your fellow Hatem because I'm learning so much with you. Okay, now I think it's time for Antoine Kimoun, another expert to help us. Now, Antoine, I think we heard from Amir that the patient looks good, but he's not good. Yes. We heard that as a fellow, we need to be a little bit stressed and come maybe more often than we think to this room. And if this patient, again, I'm your fellow as well, if this patient worsens hemodynamically, how should I manage this patient? Please tell us more.
Oh, thank you very much, Alex. Slides.
I guess Antoine's slides are coming.
Okay. So I was actually your fellow in the real life. So how to manage patients in cardiogenic shock. So here are my conflicts of interest, mostly academic. So the patient is normotensive, tachycardic, in respiratory distress with low saturation, borderline elevated lactate. The question is this patient developing a shock? Let's start with what we all agree on in cardiogenic shock in an emergency setting. The first shock diagnosis and severity rely on clinical examination and lactate levels. Second, immediate echocardiography is a key clinical exam at presentation. Third, respiratory failure should be treated with oxygen therapy or mechanical ventilation, non-invasive or invasive. But for the cardiologist, nothing should delay the transfer to the cath lab for urgent revascularization. And for me, as an intensivist, nothing should delay the restoration of systemic perfusion. So we have to start with the hemodynamic monitoring, as already said, that to help the phenotyping. We need to understand the underlying hemodynamic mechanism beyond ultrasound. We need to monitor the patient, and the best system is the one you master. So our case, the patients with the echocardiography has a cardiac index at 2.1, and with the Swan-Ganz catheter, we have, as expected, a very high cardiac index, probably overestimated by the shunt, with very high systemic vascular resistance because of the low systemic output and the normal pressure. So what is this very complex situation? It's interventricular septal defect-related cardiogenic shock. And the key pitfall is that all the measured cardiac index does not reflect systemic flow with a very high QP-QRS ratio. So low systemic cardiac output, vasoconstricted phenotype, and increased PCWP. It's a cold and wet phenotype. Another situation, the same patients but different with no septal defect. The cardiac index on the echocardiography is similar to the one you get from the Swan-Ganz catheter, so with very high PCWP and high systemic vascular resistance. And as you could see, the saturation, the mixed oxygen saturation venous is low. So it's a less complex situation. It's a typically classical MI-related cardiogenic shock, normotensive, low cardiac output, vasoconstricted with increased PCWP. It's a cold and wet phenotype also. Sorry. I don't know how to get back. Another situation is with low arterial pressure, with normal PCWP, low cardiac index, very high systemic vascular resistance. The patient is hypotensive with low cardiac output. He is vasoconstricted with low PCWP. It's a cold and dry phenotype. Finally, another very complex situation is mixed shock, septic patients with septic cardiomyopathy, for instance, post-cardiotomy, post-cardiac arrest, or long-standing cardiogenic shock, hypotensive, low diastolic arterial pressure, low systemic vascular resistance with normal or low cardiac index, but not so low with high saturation, venous saturation. It's a warm and wet phenotype. How this clinical phenotype will help us in managing this patient? First, we have to exclude preload dependency. It's in all guidelines, in all review, including in the last one from Holger Thiel. But in fact, we do not know how to comment preload dependencies in cardiogenic shock. We are not sure how to assess preload dependence in cardiogenic shock. But we clearly know the dangers of fluid overload. How to manage vasoconstricted phenotype without septal defect. So we have to prescribe hynodilatators, agents with both positive hynotropic and vasodilator effects. They should be used in low cardiac output patients resulting in tisular hypoperfusions with maintained diastolic arterial pressure. Free molecules, beta agonists, calcium synthesizer, and type 3 phosphodiesterase inhibitors. To be honest, there is no proven difference between hynodilatators and mortality. We don't even know if dobutamine is effective versus placebo, and we are still expecting the result from the DOREMI-2 trial. But dobutamine's short half-life is, at the bedside, the most practical choice for any intensivist. So what is the correct dose 5 microgram per kilo per minute is probably a good compromise because any higher dose should be tested very cautiously as it may be associated with more vasodilatations and more norepinephrine, for instance. How to manage our specific case with septal defect? It's highly complex. I will only talk about medical treatment. So the main goal is to decrease systemic vascular resistance, to facilitate left ventricular ejection into the aorta, to reduce left to right chain, to improve effective systemic flow. How do you do that? With hypotensive drugs, non-invasive ventilation, mechanical ventilation. And we need to avoid inotropes because they increase left ventricular pressure, they increase the shunt, and thus they decrease the systemic flow. Finally, another very complex phenotype, the mixed shock. And for this phenotype, we need to prescribe inopressors, molecules used to induce vasoconstriction and to increase cardiac contractility. Should be used in patients with low cardiac output, resulting in both hypoperfusion and vasodilatation, low diastolic arterial pressure. 3 molecules, dopamine, norepinephrine, epinephrine. You can forget dopamine because this molecule is associated with an increased risk of death in the SORB2 trial because of an increased risk of arrhythmia. So we have norepinephrine, epinephrine left, 2 very similar molecules, but as you could see, epinephrine displays a more potent beta-2 agonist effect. On both sides of the Atlantic Ocean, we all agree that norepinephrine is the first line agent to prescribe in mixed shock. But why? Maybe because of this very small clinical trial, epinephrine versus norepinephrine after acute myocardial infarction-related cardiogenic shock, enrolled only 57 patients and for the primary outcome, no difference in cardiac index and mean interior pressure. But to be honest, we all remember only the safety outcome. There are much more refractory cardiogenic shock in the epinephrine group compared to the norepinephrine group. So norepinephrine is the best inopressor, first line inopressor in vasoplegic cardiogenic shock. So to conclude, in general case, in case of vasoconstricted shock, we need to improve cardiac output and to restore perfusion, and dobutamine is the best drug to date. In case of mixed shock, we need to improve at the same time vascular tone and cardiac output. So we need to prescribe inopressor, inodilatator, norepinephrine, and then dobutamine. And for the rescue therapy, I will let my friend continue. Thank you very much.
Thank you very much, Antoine, for this excellent discussion. And now we're very interested to hear from Salvatore the progression of the case. So please tell us, Salvatore, what happened to this patient? We're very keen to know.
Always aim to implant a stent as soon as we can, but we don't maybe put much care on the patient. So let's move on the case again. If you remember, so this patient is still in the Spoke Center, and they just discovered inside the cath lab this ventricular septal defect. The patient is in a SCI-B, let's say. So they decided to implant an intra-aortic balloon pump 1-1. So at that stage, so there was no need for any vasoactive drugs. The blood pressure is still fine, although the patient is with some tachycardia. And they managed so to transfer the patient to our center, so to the hub center. Then the patient, when he arrived, so he was still fine. So as you may see here, so still with SCI-B, and the value that you may read here are not, so bad. And then, so it was decided that therapy made mainly on furosemide, so in order to aim a negative iliac balance. The intra-aortic balloon pump was maintained, and everything was set for making a surgery in a few days, not only thinking about the prostate loading dose, but also thinking, for example, Marina said that the tissue is fragile, so it's always good, to wait some days. Then in the first day, the patient was still fine, so nitroprusside was started because they wanted to reduce the resistance with the blood pressure mean maintained more or less around 70-75, and it was actually set in the clinical history that in case of any clinical worsening, so there was a low threshold for going to ECMO. The patient is still on intra-aortic balloon pump. On day 3, so there was a hemodynamic worsening of the patient, just because, as usual, so the patient had an atrial fibrillation. So the fact that they lost the atrial contribution to the ventricular ejection fraction, so it made a worsening in his blood pressure. And for that reason, so actually the scale moved from B to D, and it was decided to have an ECMO on the top of intra-aortic balloon pump. Then on day 6, finally, so from admission and counting 5 days that the patient had these atypic symptoms, so the patient received surgery. So there was, as usual, a ventricular septal defect repair, plus a surgical left appendage closure, as the patient had this atrial fibrillation. ECMO was removed at the end of the surgery. Intra-aortic balloon pump was still maintained. And as you may see here, so there was still some switching from of the flow from the left to right. And then after that, so as you may see here, the patient was needed still some dobutamine, noradrenaline. The intra-aortic balloon pump then was removed at day 11. And then finally, the patient was improving up to the discharge, which happened 15 days more or less after this admission in our center. The patient was referred to a rehabilitation program. And actually, I checked the patient a few days ago for this course, and the patient is still fine, so with a normal life and totally stable. And
Thank you.
This is actually all the story about our patient.
Thank you very, very much, Salvatore. We are so happy to see that the patient is really doing fine. Hatem, we heard intra-aortic balloon pump, we heard ECMO. You are the top expert. Tell us, what are the learnings, and more importantly, what is recommended in those difficult scenarios?
Sure. So, Alex, we are going to briefly discuss in the next few minutes the latest data we have on the role of short-term mechanical circulatory support in these patients. We need to remember that mechanical circulatory support in these patients is a bridge, so bridge to surgery or bridge to transplantation in some patients. And this is an interesting retrospective study from Prague, published by Daniel Robb and his team, which showed that patients who obviously presented with hemodynamic stability and no shock had the best outcome, while patients who presented with shock and received ECMO had much better survival than patients who presented with shock and did not receive ECMO. And even the study showed that almost all patients who were shocked and did not receive ECMO, they all died at 1 year, which shows the value of ECMO in these patients. And also, they proposed this algorithm, which provides a guidance for the type of mechanical circulatory support to use. In early grades of shock, SCI A or B, intra-aortic balloon pump is probably more valuable, while in higher grades of shock, SCI C onwards, balloon pump is not enough to provide systemic perfusion, and that's why microaxial flow pumps and or ECMO are needed. And we need to remember that mechanical circulatory support comes with a high price, which is the potential risk of bleeding, infection, leg ischemia. So the utilization of mechanical circulatory support has to always take into account these potential side effects. And the guidelines and the latest recommendations from Europe and the United States still show that the use of intra-aortic balloon pump is recommended as a class 2A level of evidence C in patients with acute coronary syndrome with mechanical complications of myocardial infarction, including, of course, VSD. And another interesting registry, a European registry, was based in France by Clement Delmas. The registry showed that there was heterogeneity in the utilization of Impella and other microaxial flow pumps along with ECMO between centers. And it also showed that patients who had the best outcome were the patients who had the Impella support as a bridge to operative surgical intervention. as compared to patients who had percutaneous closure who had significantly less and less favorable outcome. And this is a very nice, interesting simulation study which showed the hemodynamic effect of various types of short-term mechanical circulatory support. And here you can see the pressure volume loops. And this simulation study demonstrated that the combination of VA ECMO and Impella, which is known as ICMELA, had the best unloading and the best effect, while intra-aortic balloon pump alone had the least effect and the least unloading of the left ventricle and reduction of shunt. And finally, we need to remember that ECMO is like a parachute. And I really like this metaphor because it's a reminder that we need to use it at the right time. If we open it too early, we probably expose the patient to a high risk of complications. And if we open it too late, it is probably futile and less likely to help improving the outcome. And the final word I would like to say is about the value of shock teams. And we are here an example of that shock team and heart team, which demonstrated improvement in survival. This is an observational study from the United States, which enrolled patients over a year from 2016 to 2017, and it clearly showed improvement in survival in patients who presented with acute coronary syndrome cardiogenic shock. The survival even increased from 40 to 80%, which is quite substantial. And that's the visual display of the significant change in the survival and the improvement in mortality across the years. And we can see that the shock teams and the heart team approach had the best improvement in survival since the revascularization era. And that's what the North American registry demonstrated. And my final take-home message, I think early MCS in post-infarction VSD with worsening shock need to be considered. IABP still recommended in early cardiogenic shock, probably in SKY A and B. And it is very important to consider the center experience, the patient volume, the multidisciplinary team, which will enable standardization of protocols and early referral from the hub, from the spoke centers to hub centers, which will hopefully improve outcome.
Thank you very, very much, Hatem. Amir, you are part of one of the largest shock center in your country and the world. Can you tell us what are the recommendations for the physicians who are listening to us? A shock center, is it needed? Is it not needed? If you are going to set up a shock center, what facilities should we have in those shock centers?
Well, thank you very much. And I think Hatem got it very precisely. The fact of this discussion is actually makes the whole issue of the shock centers as a top line, because the MI shock, especially with mechanical complication, is very complex, and you need all the disciplines all together. Specifically with the VSD, very short comment, we are talking about a very specific pathology in the meaning of double jeopardy, because we don't have a cardiac output on the left side, and we have a high burden on the RV on the other side of the heart. Now, even if you're taking just to make a point of how complex it is, when you're using an ECMO in a VSD patient, the increase of the afterload that is done by the ECMO is very bad for the VSD per se. Okay, that's on one hand. So when you're talking on Impella, on the other hand, that may be very, very good. On the other hand, if the VSD is reversed because of the Impella, then you're going to get hypoxemia and reversal of the VSD. So not only the decision, the first decision, but the continuity of the care and the monitoring by the multidisciplinary in the shock centers is vital for the sake of the patient.
It's a very good question. I'm going to come back to Salvatore. Salvatore, when the ECMO was introduced in this patient, I'm sure you had a heart team discussion, and you had some people saying, "Oh, please do not increase any afterload or any parameters of afterload in the aorta, because this is not going to help my sick left ventricle." And others said, no, the patient is worsening, we need to do something. How did you handle this?
Yeah, I mean, as I told you, so the discussion was at the beginning, not to put the ECMO immediately, So it was just the discussion, so just keep the patient as stable as we can, so without ECMO, etc. And then at some point, I think the point of no return was the atrial fibrillation, because so it was discussed when the patient arrived. So to have just a low threshold for ECMO, because that was I mean, the way to save the patient if, for example, the condition were worsening. And actually, the condition were worsening when there was the atrial fibrillation. So atrial fibrillation actually put everyone agree about ECMO needs, because otherwise there will not be any option for this patient.
Yeah, thank you, Salvatore. Amir, I come back to you. This discussion that we have with Salvatore, should we do this? When should we put the MCS? And also, what MCS? Because, I mean, you started this. How, in your shock center, can you tell us what discussion you have? Does a shock center that is going to open anywhere in the world, should they have all the MCS techniques to really have like a personalized management? What would be your recommendation?
Every shock center needs to concentrate on what on several few ones. You don't have to have all of the options, okay? But I think that obviously intra-aortic balloon pump, ECMO, Impella, IE, tandem heart, all of these would be beneficial in combination. And I think that the combination is a key factor in two means. One is, should we have a mix of mechanical circulatory support, okay, which is not clear even with patient without VSD. When you do a venting for the LV, if you do a routine venting, a preemptive venting, or only on crisis, and the other issue is what kind of venting you do in addition to the ECMO. There are centers who are putting an intra-aortic balloon pump ahead of time. We do it in our center as a preemptive strike, but this is not the custom, and it's not fully scientific backup for that. So I think that there are a lot of questions ahead of us, and VSD is just unmasking all of these questions because it comes to the bottom of it.
Yeah, it's rare case, but very, very difficult cases. Hatem, let's look on the intra-aortic balloon pump. As you know, there is this trial, and there was a recommendation, as you showed earlier, 3. However, we have a VSD here and an intra-aortic balloon pump. I mean, should we throw away intra-aortic balloon pump? Is it the best indication? What would you advise to the centers who are not shock center, like Amir's case, but who would like to save the patient? And the spoke center did very well in this case. I mean, what kind of recommendations could you give us?
Absolutely, Alex. I think the spoke center did a great job, and I think the timing of balloon pump is very important, especially in early shock, and in centers which does not have other types of mechanical circulatory support devices. Definitely putting a balloon pump is better than just using inotropes, because it temporizes the patient, and then they refer the patient earlier to the hub center, which is supported by the guidelines. So we're now based on the level of evidence we have, it's a class 2A, which is recommended. So I would say definitely balloon pump is available. It is easy to insert. It can be even inserted at the bedside in very acute patients. So I would say we should support colleagues using balloon pumps, because it might be the only tool that they have in these patients.
Then I guess there is a consensus here to say in spoke centers who are treating IMI, the minimum is to have an intra-aortic balloon pump, because it may help. Always would you agree?
No, I agree with that. I think in rural areas where balloon pump may be the only expertise available to hand, and it lowers afterload, and I think, Amir alluded to it, I think it's a really good option together with inotropy that Antoine was talking about. And then speaking to your hub center, getting the patient across to a surgical center is critical.
So I have a question for Marina. So could you tell us about the type of surgery here? Would you recommend the operative approach or the percutaneous approach? Would you consider CABG in this patient? So what would be your approach?
Most of the time, it's an open heart surgery. The principle is to close this ventricular septal defect with a patch. And of course, percutaneous approach is also possible, but not always in the same patient. We don't have to compare surgical approach and percutaneous approach because these are not the same patients. And it's in front of a big ventricular septal defect, it's impossible to propose percutaneous approach. So it's really challenging, and especially because these patients are really fragile, tissues are fragile, patient is fragile, and finally, we do well what we do often. Unfortunately, this kind of patient is really rare. And as everybody tells, it's important to refer this patient in a place where we have shock team, all the tools, all devices, mechanical circulatory support, and about the...
And you mentioned the tissue is friable. How long would you wait before surgery?
As long as we can with a safe patient. That's why it's important to put the patient on mechanical circulatory support to unload the left ventricle. And I think at least 7 days, and if it's possible, a little bit more, to have a good fibrosis. Concerning the CARBAGE, nobody knows if we have to perform CARBAGE or not. Studies are not always don't have always the same outcomes. And in the study where Antoine was involved, they showed that, a French study, they showed that it was better to perform CARBAGE or not. And most of the time, VSD is linked to a single disease, to a single vessel. Vessel is okay with the cross-clamp time, just 10 minutes more. I think if there is viability, it's also linked to that point.
Sure.
If we have viability, yeah, I think we have to perform the CARBAGE.
Great. And Antoine, you published recently a French series. What do you think about the timing? Because you demonstrated that delayed surgery, was it better than early surgery?
Definitely, yeah. To be clear, there is almost no evidence on this topic of ventricular septal defect. And intensivists expect surgery early. Surgeons expect delayed surgery. It's a shock team discussion for an in-between, a good balance between a too delayed or too early surgery. So that's exactly why we are here.
Okay, thank you. Then your study is in fact clearly showing that
delayed is a good option.
Is a good option, and this is really it's a good message I think we have here. Salvatore.
One comment is that the American guidelines, which usually prefer the very early crushing surgery, now are more liberal and are closer to the ESC recommendation. So they are also on the other side of the ocean, moving for the delaying surgery rather than the immediate one, just of note.
Thank you, Amir. We have questions from our colleagues who are listening to us. The first question is for Antoine. Antoine, this patient had an IMI.
Yeah.
Then we are in an ischemic environment. He has this ventral septal defect. Among all the drugs that you mentioned earlier, if, again, we are rounding, the patient is doing fine, but he's going to worsen during the night, the question is, which inotrope would you recommend? If you have one compared to the others, knowing all what we heard, we should avoid increasing left ventricular afterload, we should avoid increasing arrhythmia related to ischemia. What would be your favorite?
Probably no one. I think that when you think about inotrope to increase systemic output, it's too late to play with drugs, and we have to think about mechanical circulatory assistance, clearly. If I have one, to test, because the patient is normotensive, maybe to try low dose, but very low dose of dobutamine. But in my mind, I will put on ECMO very early.
To avoid all the side effects.
The side effects of inotropes, increasing the shunt.
Then again, thank you, and please send us even more questions. Salvatore, when the case was discussed in your shock team, did you discuss surgery versus percutaneous repair, and what was the outcome of this discussion?
Yeah, the discussion started when the surgeon says no, but in this case, surgeon said yes. And to me, personally, I agree, and also my colleague, in my hospital, agree on that surgical repair should be the treatment of choice for this patient. So also, looking back at the patient that we have treated over, for example, the last 10 years, so when there was no so wide access to ECMO, etc., so the surgeon was a little bit worried. So we were making maybe more percutaneous closure of this ventricular septal defect. But as I said by Marina, so this tissue is very fragile. If you want to closure by percutaneously, so you may end up enlarging. So this is a ventricular septal defect because you are creating tension, and of course you are not a surgeon, so you don't have the view on the operating field. So to me, it should be clear that the ventricular septal defect should be treated by surgical operation instead of percutaneous. And all in those cases were with a very high or inoperable patients, so very high risk. So in this case, you may, consider percutaneous, but so taking in mind that the treatment cannot be so effective as, for example, surgeon, because of the fragile tissue. And as I said, you may end up with an even larger ventricular septal defect than you started.
Yeah, thank you very much, Salvatore. Always. Maybe we forgot an option, and this is a heart transplant. If the case is dramatic, is it something you would discuss inside your heart team?
Yeah, absolutely. I think that's a very good point, especially for this gentleman who's 58 with no premorbid issues. His BMI is in range. Definitely the gold standard is surgical repair of the VSD, but I think you have to keep in mind that that is a high-risk operation. It may not go well, and you need a get-out-of-jail sort of card as well. So I would encourage people to engage in a discussion with the patient whilst they're awake, and they're able to communicate their wishes, so you can explain that they may wake up on the transplant list, or may wake up with a durable LVAD or some other kind of mechanical support. But I think definitely LVAD transplant is an option that should be kept in mind.
Okay, and you would say to the patient early on, saying this may be an option?
I would. My personal view is yes, and that's our practice at Harefield. I think it's sort of having plan A, plan B, and plan C, so everybody in the team is aware of where the patient's heading and what to do if this happens and if this doesn't work, and having everything prepared. I think preparation is key to good outcomes.
Very, very good. Now, I have a secret to tell you. Salvatore didn't tell you, but the patient is doing fine, but he's going to England.
Right.
and now you need to do the post-surgical, even the post-discharge management of those patients. Yeah. What should we do? Is nothing bye-bye, or is there some sophisticated thing to do?
No, this is a great question as well. I think the journey isn't over. Once the inotropes are weaned, I think guideline-directed medical therapy for heart failure is really key. So if the ejection fraction's reduced, you want to be on the 4 pillars. If the ejection fraction's preserved, that you definitely need to be on SGLT2 inhibitors because that will lead to better outcomes for the patient, both quality of life and mortality as well.
Yeah, and this also needs to be explained to the patient, also explained to the general practitioner.
Absolutely.
Probably you would ask this patient to come again and again because to make sure that everything is fine. But I think we all agree that it seems a little bit counterintuitive to give beta blocker or drugs like this, but it is so important. And there are data today to show in cardiogenic shock, preliminary data, but in cardiogenic shock patients, if the ejection fraction is low, giving GDMT is markedly improving outcome compared to patients after cardiogenic shock that didn't have GDMT.
Yeah, I couldn't agree more. I think doing it safely in hospital as well. Yeah.
Hatem, it's your turn. Well,
Thank you.
did we learn something from this session?
I personally learned a lot in this session. Lots of key messages to take with us. We learned that early referral is very important, and early diagnosis in these patients is life-saving. So very important to recognize them very early on and to have agreement with other hub centers for quick shock teams, shock calls, referral pathways. This is very vital and very important. We also learned that balloon pump still has a place based on the available evidence, especially in early stages of shock. But generally, to our colleagues, when you encounter these patients and the only MCS you have is balloon pump, please don't hesitate and call early the specialist centers. We also learned that closure after the VSD, after MI, is crucial to improve survival, and probably delayed closure 7 days onwards is preferred in stable patients. We also learned that the use of imaging and echo is very important to quantify shunts. And in patients who have complicated shunts, which are difficult to quantify by echo, very important to have the invasive hemodynamic assessment, which is also important for surgical decision-making. The shock team approach is very, very vital, which is what we had today in this session with this distinguished group of experts. So very important to work together, listen to each other, and try to do the best to our patients. And also, we learned that all the data we have in this complex area is from observational studies and registries. We don't have any randomized data, unfortunately. So this is an area which requires more research and more randomized controls trials. So at the end, I would like to thank my distinguished colleagues for this wonderful session. As I said, I learned so much and I enjoyed it, and I hope you also enjoyed being with us. We really encourage you to register to iHF and follow all the educational content that will be regularly posted online, and also follow up for the recording of this session, which will be soon on iHF website. And we hope that you enjoyed the session, and we hope that you enjoy the rest of iHF 2026. Thank you very much.
Good morning. I'm Dr. Joseph Vincelli from Sant'Andrea University Hospital, and it is really a privilege for me to be here today on behalf of my research group to present this clinical case entitled When Valves Collide, Managing Acute Heart Failure in the Real World. This case is about a 78-year-old female with a BMI of 25.2. Her cardiovascular risk factor profile includes arterial hypertension, dyslipidemia, and peripheral arterial disease with prior right carotid endarterectomy. The patient is also known for atrial fibrillation, chronic kidney disease, chronic obstructive pulmonary disease, and prior breast cancer. She presented with progressive class 3 dyspnea on top of recurrent presyncopal episodes. And this was medical therapy she was on at admission. A transthoracic echo showed preserved ventricular ejection fraction with no regional wall motion abnormalities, while valve assessment revealed combined severe valvular heart disease, including posterior mitral leaflet chordae rupture and flail associated with severe MR and moderate to severe tricuspid valve regurgitation. We discussed the case within a multidisciplinary heart team, and we decided to proceed with a percutaneous edge-to-edge mitral valve repair first. Consequentially, we performed M-TEER with the implantation of one XTW device followed by one NTW device implanted posterior to the first one, No complications were observed, and a post-procedural TT confirmed the success of the procedure, showing significant reduction of mitral regurgitation to mild to moderate grade and a mean transmitral gradient of 2 mm of mercury. Nevertheless, the patient was readmitted due to acute decompensated heart failure in the setting of severe anemia. After clinical stabilization, she underwent esophagogastroduodenoscopy with endoscopic duodenal polypectomy, followed by a colonoscopy revealing multiple colonic polyps. Given the high bleeding risk and the need for definitive discontinuation of her cardioembolic prophylaxis, a percutaneous left atrial appendage closure was performed after heart team discussion. The device of choice was the Amplatzer Amulette 28. We observed no complications, and the patient was discharged with hemoglobin value stably above 10. At follow-up, patient reported persistent class 3 dyspnea. Echo assessment confirmed the good outcome of the MTL procedure previously performed and showed a severe tricuspid valve regurgitation. A transesophageal echo revealed a 3-leaflet tricuspid valve morphology, a central jet with a graded component between the septal and anterior leaflet, a coaptation gap of 4 mm, and an optimal echocardiographic view for leaflet visualization. Subsequently, we performed right heart catheterization with the evidence of precapillary pulmonary hypertension and with the evidence of pulmonary vascular resistance at the upper limit of normal. We brought back the case of the patient within our multidisciplinary heart team, and we decided to proceed with TTR. A transcatheter edge-to-edge repair for this tricuspid valve regurgitation was then successfully performed with the implantation of one 3-clip G4 XTW device between septal and anterior leaflet, achieving procedural success with mild to moderate residual TR. A pre-discharge echo showed stable 3-clip position, and a 60-day clinical follow-up patient reported a significant improvement in dyspnea and a full functional independence with a marked improvement in her quality of life. Wrapping up, we know that acute decompensated heart failure is often due to valvular heart disease. Nonetheless, assessing the severity of valvular heart disease may be difficult because of the rapid variation in loading condition, because of concomitant destabilization of the associated comorbidities, and because of the presence of multiple valvular heart disease. Moreover, there's only limited data in the literature and in the current guidelines to support and guide clinical decision making. Therefore, therapeutic management strategy should be individualized by a multidisciplinary heart team, considering the single valve severity, the individual patient risk, the natural history of each valve lesion if eventually left untreated, and the prosthesis-related morbidity. The intervention is indicated in the presence of symptoms or ventricular dysfunction, starting with the most distal valve suitable for percutaneous treatment. We also add that in select patients with atrial fibrillation and contraindication to long-term anticoagulation, a percutaneous left atrial appendage closure represents a valuable adjunctive strategy to reduce thromboembolic risk. Thank you for your attention.
Good afternoon, dear colleagues. It's a pleasure to welcome you at this session on precision pathways in patients with aortic stenosis awaiting TAVI, ACT Beyond Symptoms. I'm Josef Batunek from Aarhus, Belgium, and I co-chair this session with Emanuele Barbato from Rome, Italy. We are privileged to be joined by a panel of distinguished colleagues. Online, Dr. Lorena Hill, here in the studio, Dr. Giuseppe Rosano, and Mark van der Heijden. We recognize increasingly that the aortic valve disease is not a simple valve disease. We recognize that it is impacted by symptoms, and the trajectory is impacted also by a number of cardiac, extracardiac factors. And in this context, the session's objectives are as follows. We try to understand diagnostic pathways, including staging, and their complementary value in improving the precision of the TAVI workup in significant aortic stenosis. We learn about the clinical relevance of targeted screening for comorbidities in significant aortic stenosis. And finally, we wish to appraise the right timing for intervention beyond symptoms onset.
That's a very nice outlook, Joseph. What we need also to anticipate to our colleagues is that we will do this through two extremely interesting cases that were selected from our speakers. But what's most important is to remind our colleagues that this is a very interactive session. So do not forget to share your thoughts, your questions, your comments through the chat box. I'll make sure, because I have the iPad here next to me, to convey your discussion points to the colleagues here in the office. I think we are ready to get started and to give the words to the first presenter, Sara Corradetti. Sara, you are with us. The word is yours.
Yeah.
If you can introduce us with the first case.
Yeah, good afternoon to everybody, and thank you for the invitation to present this first case we are going to discuss all together. So, the patient is an 86-year-old man complaining progressive fatigue and increasing dyspnea over the past months. His past medical history included a previous stroke, paroxysmal atrial fibrillation, and type 2 diabetes, treated with both oral medications and insulin. The patient had no signs of congestion, but we detected a systolic murmur during the clinical evaluation. The renal function was preserved, but we found an elevated NT-proBNP at above 1,000 and mildly elevated high-sensitivity troponin T at 27 picograms per milliliter. The ECG showed sinus rhythm with non-specific repolarization abnormalities. Regarding transthoracic echocardiography, it showed a mildly hypertrophic left ventricle with moderately reduced ejection fraction. The left atrium was enlarged and the right ventricular systolic function was preserved. In addition, the echo showed a severe diastolic dysfunction with elevated left ventricular filling pressures and an average E over E prime ratio of 28. The evaluation of the aortic valve revealed a low flow, low gradient severe aortic stenosis, presenting an average aortic valve area of 0.67 square centimeters and a mean gradient of 27 millimeters of mercury, with a reduced stroke volume index around 29. Speckle tracking analysis showed a reduced global longitudinal strain of approximately -11%, with a pattern of relative apical sparing. And myocardial work analysis also confirmed the impaired myocardial performance. As part of our standard diagnostic workup, we then performed a left and right arc catheterization that confirmed the hemodynamic severity of the aortic disease, showing an invasive mean gradient across the aortic valve of 40 millimeters of mercury and an aortic valve area calculated by the Gorlin formula of 0.70 square centimeters, confirming severe aortic stenosis. Finally, we performed a coronary angiography that showed that diffuse atheromatous with no significant obstructive coronary artery disease.
Thank you, Sarah, for this very interesting case presentation. And I think there are a number of interesting factors here. We have a patient, elderly patient, low EVF, no remodeling, no dilation, hypertrophy, low flow, low gradient aortic stenosis. So I would like to ask maybe first, Mark, if you would see such patient to outpatient clinic, what would be your workup? How would you approach this patient?
As already told also and seen in the case Sarah was presenting, we always do a left and right heart catheterization in these patients. We don't only want to have information about the valve hemodynamics, but we also want to know much more about left ventricle, right ventricle. And we think this is very important to know this because we want to stage the patients. Is there only right ventricular? Is there only left ventricular dysfunction? Is there also right ventricular function? What are the pulmonary pressures? And according to this hemodynamic assessment, we can stage these patients appropriately. Coming back to the case we discussed, this patient has a low flow, low gradient, stage 3 aortic stenosis. That's how we stage it.
That's interesting because you mentioned that we should do a right heart catheterization. Classical staging that was described initially was not really focusing on that aspect. Could you maybe elucidate to us, to what extent this information is more, I would say, informative about the decision making?
It helps in the decision making because we know that the initial staging was echocardiographic based. We were able to demonstrate that there is a lot of patients in stage 1 and stage 2. When you do the right heart catheterization, you can better categorize these patients, and we know that staging is related to outcome.
So basically we better understand the hemodynamic impact on both sides of the heart, in fact.
That's what we want to do. And especially in these patients, it's extremely important because they are already very fragile.
That's right, also because we have also low flow, low gradient. Just imagine that there would be a discrepancy between the grading with echocardiography as compared to the invasive measurements. How would you try to reconcile? What would be your most decisive information to make the call about the further step?
As I'm an interventional cardiologist, I'll go for the invasive approach. And also we were able to demonstrate that a lot of these kind of disproportionate cases, as we call it, that when we do an invasive assessment, that we are much better and much more correct. We can much better measure the severity of the aortic valve stenosis.
Thank you. When we look back at the patient profile, the patient has also reduced ejection fraction. So how we are going to now basically distinguish what drives the symptoms of this patient? Is it the low flow, low gradient AS, or is it some kind of underlying cardiomyopathy? Giuseppe, what would be your thought on it?
Yeah, my approach would be to do a stress echo, first of all, in order to see what is the real gradient, but also there are some flags like the diffuse hypertrophy that look a little bit speckled, and but also was not associated with significant signs of hypertrophy on the ECG. There was reduced GLS with apical sparing that should suggest us to look further and more into details whether there is an underlying cardiomyopathy.
All right.
Joseph, I've got a question here in the chat box. Actually, our colleague Alexandre from France is asking about the role of CT in discriminating in these patients.
I think this is also a very important one. You have to do the CT just for measurements of the valve, but also the calcification of the valve. The Agatston score will help you in guide whether this is severe aortic stenosis, yes or no.
I think maybe another question here is to ask, is an 86-year-old gentleman, we don't know exactly what is his condition, we just see him for the first time, and I would maybe just put the question to Laureen about, what would you do yourself in your center to understand better about the patient, I would say profile, risk profile, eligibility for any interventional strategy?
Yeah, so that's a good question. You did say, as the slide said, he was 86. He already had the comorbidity of being a diabetic. So a comprehensive geriatric assessment would be in order. Basically, within our centre, we would check all patients for frailty, be that using a variety of tools. There's the Rockwood multidisciplinary tool, there's the clinical frailty score, there's the Freed frailty score, and also the Heart Failure Association have their own frailty score. And I think frailty is something because it's a predictor of how successful this TAVI could be. Also, if he was found to be pre-frail, then it would be something, and it would be appropriate then to really put some interventions in place to make the procedure more successful in terms of giving him nutritional and exercise advice.
Thank you, Colin. It's very informative, especially for us interventional cardiologists, because we don't do that very often. We forget that. How would you maybe yourselves advise us to use them as such in one package, or is it better tailored to certain subgroup of patients?
Certainly, it's something in terms of
all these scoring systems, or is there some more that you would favor as a first step to use?
Certainly, it can be used as a screening tool to see if this patient is frail or if they're not frail, and then there's more advanced tools that you can use to really detect and score them, and then know what appropriate interventions to put in place if it's something they can give lifestyle advice on, as I said, nutrition or exercise, or it needs more advanced therapies, which are under investigation.
There is a point, Joseph, that we should also openly discuss within this forum of experts, which is how to carefully select patients. I think it's common experience in our practices that we are witnessing a tsunami of indication. Let's put it in this way, especially now that the indication to TAVI has been lowered down from 75 to 70 years old. So in a way, we have to optimize the resources available. At least in Italy, we don't have unlimited TAVI availability. So we have to decide really where to allocate these resources. And I think the assessment of frailty, the geriatric assessment, in other words, the estimation of the futility of our procedure becomes really central in the discussion here. Let's really get into the local practice. How is the practice, Emanuele, in your institution at this level? And then I will ask the same question to Mark.
Yeah. So, well, at our institution, we are used to ask for a geriatric consultation for all the patients above 85-year-old. And this is not only to assess the functional status of the patients themselves, but also to check whether the procedure would be clinically appropriate other than clinically indicated. So that's how we are used to perform in our clinical practice.
It's a little bit similar with us. All our patients are undergoing a geriatric assessment, and then we decide together with the geriatrician whether it's worthwhile to do the TAVI, yes or no.
Thank you. This was a great discussion. We have a better understanding of what should be and can be done in this patient. Now, wrapping that up, we have a low flow, low gradient. We have a frailty assessment. Now we have also this sort of hypertrophy. And I think it's a very hot topic to understand to what extent comorbidities may impact hypertrophy in aortic stenosis patients. And thereby, I would like to have Giuseppe to present us how the amyloidosis in patients with aortic stenosis could be impactful on the presentation and the trajectory.
Yes, we have already hinted about some of the flags that were present in these patients. I mean, this is my potential conflict of interest. Now, when we see patients with aortic stenosis, especially elderly male with such hypertrophy, we have to think at amyloidosis. Now, we for sure underestimate at the present the importance of amyloidosis in aortic stenosis. We have data from cohort studies, and they go from, say, an incidence of 14 to 25%. That depends on the type of patients that are being studied. Let's say if you have a mixed cohort that is mostly moderate to severe, just coming for TAVI is around 14%. In other cohorts with older patients with some red flags, like, for example, the ones that we've seen, low flow, low gradient, maybe with a carpal tunnel, then it goes up to 25%. So that is significant. It goes from 1 in 7 to 1 in 4. And for sure, it's underestimated. And that depends also on the referral we get on the centers. But also, it's important to look at the prevalence of aortic stenosis in patients with amyloidosis, because often patients with amyloidosis then are seen by amyloidosis centers, and the presence of aortic stenosis gets downgraded. And we know that looking at what we have from the different registries, we have a prevalence between 10 to 30%. So we need to get better data, but for sure at the present, we underestimate the presence of amyloidosis. Amyloidosis is very important because it's an infiltrative cardiomyopathy that has a very important effect on valves, causing valve thickening, but also they have an effect on the ventricle, making it stiffer and hypertrophic on conduction tissue, therefore inducing atrial fibrillation or conduction defects. So it affects the heart as a whole, and that is important in order to understand what also can be put together with the valve treatment. Of course, we have red flags, and we can have some red flags like the presence of heart failure, atrial fibrillation, thickened heart, but also some musculoskeletal that we rarely tend to investigate in our patients, like the carpal tunnel, the patients that come with lower back that has never been investigated, has been put down to sciatica or the saddle, and let's say the tendon problem, especially on the biceps, and that are all signs of potential amyloidosis. Then when we get another important issue are those patients with peripheral neuropathy, but also those patients with autonomic dysfunction. Let's say you get a patient who was hypertensive, or become hypotensive, or develop postural hypotension. That is, in the early days, we used to say, okay, that is getting older, so there is a dysfunction on the regulation. There's nothing, but today we have to investigate more the importance of amyloidosis. So for cardiac amyloidosis, we know that it's more frequent in patients who are male and elderly. There are specific hallmarks that are the fact that the ECG has this low voltage ECG on the precordial leads, together with conduction abnormalities. So whenever we see this mismatch between the hypertrophy and the ECG, we have to think at amyloidosis. Also, there's on the echo, we'll see the images like the one that we've just seen in this case, but also the reduced LG and with apical sparing are a very, very good sign. So for the aortic stenosis itself, if we have a rapid progression of aortic stenosis, that should suggest the presence of amyloidosis, the presence of a worsening heart failure that is not explained, that should suggest the presence of aortic stenosis. Now, of course, there are factors that impact the prognosis of patients with aortic stenosis and amyloidosis, and we have to take into account them. So first of all is the degree of aortic stenosis, the low flow, low gradient, and the advanced aortic stenosis severity. The presence of right ventricular dysfunction, and you suggested the need of a right ventricular cath in these patients. The extent of the amyloid infiltration, the greater, the worse is the prognosis. Also biomarkers, because if we see that patients tend to have a progressive elevated NT-proBNP and troponin, that is a poor prognosticator together with a worsening of renal function. We've discussed about the comorbidities. I mean, CKD is an hallmark, and so the eGFR should always be assessed, but also the frailty. And Lorena has published in the new definition of frailty, where there is also the recovery component. I mean, frailty is not a stable state. Frailty can be improved if we change what is causing that frailty at that point in time. And here there were 2 points. One was the aortic stenosis, but the other one, it could have been also the aggressive glucose management that in an elderly patient may favor that. Another point to consider are those patients in therapies and when to start therapies. Now, we know that the survival in patients with amyloidosis has changed after, initially with tafamidis, but more recently with acoramidis and vutrisiran that can be used in patients who are naive, but also in those patients who have failed or are progressing with tafamidis. And we need to understand if a patient is on therapy, how long that patient has been on therapy for, so we can estimate what is the survival that is left for that patient and where is the trajectory. But also we have to assess and think of what is coming. What is coming is on the bottom right panel. You see these are the new depleters, and you can clearly see from the top images from the one on the bottom how the amyloidosis can be depleted, how the abnormal GLS with apical sparing goes back to a normal GLS. So we need to keep screening in order to increase the detection, see where these patients are. And the take home I would say is that the prevalence in moderate severe aortic stenosis is largely underestimated. Whenever we see patients with aortic stenosis with thickened heart, low voltages, impaired GLS with apical sparing, then we always have to think of amyloidosis. Then we have prognosticators that are the degree of aortic stenosis, the presence, the extent of amyloidosis infiltration, the degree of right ventricular dysfunction, and biomarkers change that should be always assessed together with the geriatric assessment for frailty. And for patients who are already on therapy, as in patients that have amyloidosis and already in an advanced stage, we need to assess the futility of the intervention as well.
Thank you, Giuseppe. It was fantastic, comprehensive, insightful, clear. Thank you very much for that. So let's move on back to our patient. Sarah, would you like to enlighten us about what happened to the patient, how we do proceed, and what have been done?
Yeah, absolutely. So indeed, given the clinical suspicion...
We can ask this later about this.
Given the clinical suspicion of an infiltrative cardiomyopathy, what we did is exactly a full screening for cardiac amyloidosis. The bone scintigraphy showed a Perugini score of 2, while serum-free light chains and serum and urine immunofixation were negative. Altogether, these findings were diagnostic for transthyretin cardiac amyloidosis. The case was then discussed within our ART team, where we also took into account the surgical risk of the patient and this frailty assessment. The STS score was 4, the STS morbidity and mortality was 11, Euroscore 2.7%, and both the clinical frailty scale and the Minico score were 4. So considering the overall clinical profile, the ART team agreed that a transcatheter approach was the most appropriate treatment strategy for the aortic valve disease, to be combined with a pharmacological treatment for amyloidosis. The patient underwent TAVI using a core valve Evolut 34 millimeters bioprosthesis, and in addition, disease-modifying therapy for transthyretin amyloidosis was initiated using tafamidis. At 3 months follow-up, you can already appreciate a rise in left ventricular ejection fraction and a clear hemodynamic improvement. Indeed, the transmitral Doppler parameters were much better, demonstrating lower filling pressures and a reduction in the E/E' ratio from 28 before the interventions to only 14 after. The bioprosthetic valve function was excellent, with a mean gradient of only 2 millimeters of mercury and a negligible perivalvular leak. So after this synergistic treatment with TAVI and tafamidis, the global longitudinal strain improved from -11% to -15%. And as we can see from the shape of the PV loop, also myocardial work improved, suggesting optimized ventricular loading conditions coupled with a partial recovery of the intrinsic myocardial function. At 6-month follow-up, the patient reported a clear improvement also in symptoms. He was free from heart failure hospitalization, and the NT-proBNP decreased from above 1,000 to 641 picogram per milliliter.
Thank you, Sarah. This was really nice, I think very successful. And when looking at the course of the case and a very fast recovery after the TAVI, 3 months, and the function was normalized, one would assume that the primary cause of this function was the pressure overload. I think in the context of what we discussed and what we've seen, especially with amyloidosis, the question is when we should be initiating the treatment. So I would like to ask both Giuseppe and Mark for your opinions.
I think when we diagnose amyloidosis nowadays, there has already been a long delay between the onset and the diagnosis. So there is no doubt about that you should start your tafamidis as soon as possible once you have the diagnosis. So I should start it immediately.
No, I fully agree. It's, once the patient is diagnosed, we have to start immediately. We see that in the different trials, the curves start to diverge after a little while. So if it's not at discharge, which would be preferable, then it should be done within the first month. But it should be started as soon as possible, because also together we maximize the benefit of the TAVI implantation.
What's maybe also important is a lot of our TAVI patients are octogenarians. And even in octogenarians, tafamidis can make a difference. So it's important to know.
Yeah. Very good, very good. And when you also think about this patient, also is like a HFpEF phenotype or HFmid-Ref phenotype, would you also initiate, or how would you initiate the other heart failure, GDMT? How would you optimize it?
Yeah. I think that there is space for the SGLT2 inhibitors, and we know the DAPA-TAVI has a good results, but also there are data from actually from a large Italian study that demonstrated that the SGLT2 inhibitors work very well in patients alleviating symptoms in patients with amyloidosis. So here you catch 2 birds with 1 stone by using the SGLT2 inhibitors. And also because of the preserved ejection fraction, maybe considering the MRAs as well.
Another point also maybe, and we also started in this particular patient apixaban. Your threshold for starting NOACs in patients with amyloidosis should be extremely low and is not related to the CHA2DS2-VASc score, because they are prone to AFib and they also have a higher thrombosis rate.
Very interesting. Another maybe comment is, or question is, when you see this patient, he recovered quite quickly, how often we should be following him up? I know, Lorena, would you maybe share with us your experience at your center? What is your approach to this approach? What is the approach to this patient in your center?
So absolutely. So this patient's post-TAVI and also has potentially preserved ejection fraction, so they would be followed up quite regularly to optimize their treatment in the first instance, to make sure they're treatment free. Usually the first would be a telephone call from the heart valve clinic, just to make sure they're okay, and then followed up at clinic for clinical assessment and optimization of treatment, in addition to education to ensure good self-management, be that exercise, be that fluid, be that nutrition. And also, again, making sure that they feel properly supported. It's important that this type of patient, he's 86, he's supported within his social environment. We don't have cardiac rehabilitation for this patient, but it may be something some other organizations or institutions may have that he could access.
Joseph, I've got a question from our colleague here, from Holger from Germany. It's a technical one, directed to the intervention cardiologist. Holger is asking, in this case, you have implanted a self-expandable valve. But more in general, his question is about how do you choose between a balloon expandable and a self-expandable valve in a patient with a low flow, low gradient aortic stenosis? Is there any interaction?
It's a very good question. There is, I think, only one study was comparing outcome between balloon expandable and self-expandable valves in aortic stenosis patients with low flow, low gradient, which didn't show any difference in mortality or survival. The other way around, I think you should tailor your therapy to the individual patient. For example, if you have a patient with a small annulus, I should not go for a balloon expandable. I should go for a self-expandable valve. If you expect a high chance that you have to implant a pacemaker afterwards, I should prefer a balloon expandable valve. If there's a lot of calcium in the valve and you're afraid of aortic regurgitation, then I should again go for a self-expanding valve with a skirt. So you should tailor this on the individual patient.
Thank you. I think we covered many things here. I think it's quite exhaustive and very informative. I think we can turn to the next patient.
Yeah, let's see what Emanuele has selected for us.
Thank you. So the patients we are going to present is a 74-year-old female patient. As cardiovascular risk factor, she was smoking with hypertension, dyslipidemia, and diabetes. Medical history was unremarkable, except for paroxysmal atrial fibrillation. She was admitted at our institution in March 2025 because of non-ST elevation acute coronary syndrome. So she was admitted with chest pain. The ECG showed atrial fibrillation at under 35 beats per minute, with a significant raise in troponin levels. The culprit lesion was identified in the proximal LAD and was treated percutaneously with 2 stents. Then the patient was sent to the CCU, and the echocardiographic examination showed a preserved ejection fraction, yet with a moderate aortic stenosis with a mean gradient of 21. But then, when we calculate the aortic valve area, it turned out that the aortic valve area was 0.91 and indexed of 0.62. So the patient was discharged. Then we set up all the therapy for the ischemic syndrome. Then we also set up a triple antithrombotic therapy for 7 days, followed up by a dual antithrombotic therapy. The echocardiographic examination concluded for a normal flow, low gradient, severe asymptomatic aortic stenosis. But given the clinical presentation, after a heart team discussion, we decided to discharge the patient and follow up at the heart valve clinic.
Thank you very much, Emanuele. We are dealing now with a younger patient as compared to the first one, but that doesn't mean that this patient poses less challenges. First of all, I took some notes from your presentation. Female patient, low body mass index, I think it was 20.
Around 20, yeah.
Paroxysmal atrial fibrillation acute coronary syndrome, which poses already this patient's at higher bleeding risk. But here the point of discussion, and I would like to start with Giuseppe, the point of discussion is how to carefully assess symptoms in these patients, because we need to, first of all, make sure that this is a truly asymptomatic severe aortic stenosis. Let's remind it again, this is a patient with polymyalgia, with recurrent episodes of atrial fibrillation, so we wouldn't expect that much of exercise activity here. What is your guess on this?
Yeah, first of all, that was the first encounter for the aortic stenosis. So we don't know where in the trajectory that patient is. So the first thing to do is to do a close follow-up for this patient, maybe with another assessment, a full assessment at 6 months, to see how much of those symptoms were related to his underlying coronary artery disease and whether she has improved in exercise capacity. I mean, polymyalgia plays a role, and but also we'll see whether there is a recovery and whether if she doesn't improve, then the aortic stenosis probably plays a very important role. For the atrial fibrillation, I mean, it's paroxysmal. I mean, I think we need to consider whether that was related to the ischemia, although it's unlikely, or was due to the overload of the left ventricle, given that there is a mitral regurgitation. So that is something to consider in the assessment of this patient. But what I would do is a close follow-up, look at whether the disease is progressing, and assess the symptoms to see whether that something that was asymptomatic was really not really asymptomatic, but is there are underlying symptoms that suggest that something should be done.
Further elaborating on this point of the follow-up, which is, by the way, very well taken, perhaps we can go to Lorena briefly. In your practice, this kind of patient who have a supposedly asymptomatic aortic stenosis, how would be followed up on an outpatient basis, and what is the kind of screening that you would do?
Yeah, so as you said, it would be followed up at the heart valve clinic, probably not as, probably on a 6-monthly basis. They would be seen, they would have maybe given their contact details to the heart valve nurse and the heart failure nurses to ensure that they should become more symptomatic. They can let them know. In terms of screening, there would be screening you could do for the frailty screenings. We've done functional status, could be if they're able to do any sort of 6-minute walk or any assessment of their functional status using a CATS tool or quality of life status, you could, and then when you repeat them and see them again, see if that's deteriorating, giving you some quantifiable measures as well as subjective measures, because sometimes a patient like that adapts to their physical limitations, and then it can be difficult to actually assess how quickly are they getting worse.
Thank you very much, Lorena. To Mark, to the interventional cardiologist, you know, the hands are itching. We would like to treat and get rid of this aortic stenosis. Are there any kind of diagnostic tests that could challenge this, the severity of this valve?
Again, what we should do is, first of all, we do a CT to get more information about the Agatston score. If the patient is really asymptomatic, the way we also assess this is by doing, for example, an exercise test and see what's happening. And the patient also has an acute coronary syndrome, which is also interesting. All these patients in our department, they got into a rehabilitation program. So we will observe how they behave there much more in detail, and it will learn us also a lot about whether it is a severe aortic stenosis, yes or no.
Nice. I may interrupt. There is one question here from the audience, anonymous question. It's about the red flags. You know, you mentioned the red flags. There are no red flags here for amyloidosis. Would you screen also this patient for amyloidosis?
I think there's no need in this case. There's no significant hypertrophy. There's no evidence that there could be any change. I mean, we haven't seen the electrocardiogram, but it's if that was allows, then we can see that there are no signs of overload. So in that case, I wouldn't go too much along that path.
We mentioned the role of right heart catheterization. Does it play any role in this specific case, Mark?
Again, it can give us some information about the extravalvular involvement. We will learn much more about pressures in the right ventricle, pressures in the lungs, the PCW we will know, and we again can stage the patients then according to what we find. And we also know that this is a moderate aortic stenosis for the moment, that in these patients this staging can help us because we know that the higher the stage, the higher will be the morbidity and mortality. So it can definitely guide us in better categorize these patients. But we have to do it after the acute event.
Before going back to Emanuele and listen to the further treatment of this patient, I'd like to pull in within this discussion Sarah, because I know that Sarah is doing her training in a center where lots of left and right heart catheterizations are performed. How are normally invasively assessed, Sarah, these patients in your practice in Aalst?
Yes, well, we used to perform left and right catheterization when we are in doubt if the aortic stenosis is moderate or severe. And what we noticed is that sometimes we have a discordancy between the measurement that we obtain by the echo and a measurement that we obtain from the right heart catheterization. Especially if we reclassify the patient based on the cardiac output that we obtain by the right heart catheterization.
Mm-hmm. This is a very important point that we tend to forget nowadays. This kind of patients would only get, if any, an injection of the coronary arteries, but we know nowadays the role of coronary CT is even taking away this pleasure of our hands, but we listened to Sarah how important it is to invasively assess this patient also through a complete left-right heart catheterization. Are there any other questions for the moment?
For the moment, no.
If not, okay, we get back to the case then.
Okay, so let's go back and to recall the first part. So we are facing a patient with normal flow, low gradient, severe aortic stenosis. The patient was called back at 6 months follow-up at the heart valve clinic. She was in a very good clinical condition. She had no longer chest pain and she was barely asymptomatic with known or only mild dyspnea. Also, laboratory tests were unremarkable and NT-proBNP was normal per age. The echocardiography showed a normal ejection fraction, yet it is a small ventricle, but if we look on the right, we clearly see that there is a moderate mitral regurgitation along with the severe aortic stenosis that we have already seen in our previous part. So the hemodynamic profile did not change at 6 months follow-up. We still have a mean gradient of 29 millimeter per mercury. So we decided to follow up the patient. However, 1 month later, the patient was again admitted at our emergency department because of worsened dyspnea, class NIA 3 to 4. Again, the ECG showed atrial fibrillation with under 20 beats per minute. This time, laboratory tests clearly show an increase of inflammatory marker like white blood cells, along with an elevated CRP, and the NT-proBNP was significantly and markedly elevated with 5,180 picograms per milliliter. Therefore, the patients were treated with oxygen, diuretics, amiodarone, and antibiotics. Echocardiographic assessment showed an unchanged hemodynamic profile with the mean gradient of 33, so still the hemodynamic profile was the same, normal flow, low gradient, severe aortic stenosis. Now, considering the clinical presentation, we assessed the risk profile of the patient that was quite low with a frailty score of 1 and Euro score 2 of 1%. Therefore, we discussed at the heart team the case that concluded for a decompensated heart failure in a patient with severe aortic stenosis and acute bronchitis with a normal flow, low gradient hemodynamic phenotype, and we decided to move forward with the TAVI. The TAVI was performed through transfemoral approach, and Navitor 25 was implanted. The patient was called back 3 months later for a follow-up. As we can see here, the mitral regurgitation was actually reduced, so this is going to be likely a mild mitral regurgitation from the moderate that we had at the previous follow-up. And then, of course, the bioprothesis was working properly with a mean gradient of 4 millimeters per mercury. And that's it.
Thank you very much, Emanuele. Lots of points of discussion, really, that we should carefully dissect one by one. The first one, to both Mark and Giuseppe. We have entailed the first part of the discussion around the consideration whether this was a truly asymptomatic patient. Now, It took just one episode of paroxysmal atrial fibrillation to get an acute heart decompensation in this patient. Of course, risk stratification is always a dynamic process and should take into account events that might occur. Is this patient any more asymptomatic, or are we ready, as the colleagues did, to consider this patient as truly symptomatic and therefore candidate for aortic stenosis treatment? Who wants to go first?
No, I think that there was a clear reason for the decompensation. I mean, the decompensation was precipitated by the COPD, an acute respiratory event, that led to an left ventricle overload, and that led to, together with an increase in the regurgitant flow, and therefore further dilatation and increase in pressures in the right atrium that have most probably have induced the atrial fibrillation. So if you unload the left ventricle, then, and as we've seen after implanting TAVI, the mitral regurgitation became negligible, or minimal, then I think that there was a clear reason both for the worsening, but also for the episodes of paroxysmal atrial fibrillation that this patient has experienced in the past. So I think there's a clear cut, and the TAVI is clearly indicated, and most probably these patients won't need any further electrophysiological intervention. I don't know whether Mark agrees with me on.
Well, let me ease him out, because it's too easy. It's too easy for him. No, wait. Let me reformulate the question to you, because I'm sure you would be ready to implant a TAVI here. But why not doing atrial fibrillation treatment first, since it was the cause for the acute decompensation of this patient?
You know, we had a bit of discrepancy between the panelists about this. And I'm puzzled by the fact that 3 months after his acute MI, the guy had, or the lady had a BMP of 500, which indicates for me that she's quite well. She's doing well. And this makes, for me, it's extremely interesting. I think that the AFib is responsible for the acute deterioration. I'm not sure, and the proof of the pudding is in the eating, whether this patient will not develop AFib anymore after she got the TAVI nowadays. So you will have to tell me in the coming years, in the coming months, whenever she develops it. But to be honest, I should also do the ablation, and then in a second time, I should do the TAVI.
Okay, that's an interesting perspective, which is not exactly in line with what Giuseppe said, but that's the beauty of the heart team discussion. So let's move one step forward. These kind of issues, they seldom come alone. In other words, when you have an aortic stenosis, it comes very often associated with a mitral regurgitation. We have seen also the echocardiographic follow-up, MR assessed before the TAVI, MR assessed after the TAVI. So, Giuseppe, in your experience, in your practice, what is the strategy here? Treat the downstream problem first and see how it evolves the upstream problem, or would you tackle them both?
I think that the main problem there was the aortic stenosis, and that was clearly precipitating everything. Because there was a clear evidence for the increase in mitral regurgitation, and whenever there is an intercurring event like COPD, but it could have been also, say, knee pain that required NSAIDs or anything else, that would have precipitated the volume overload and the atrial fibrillation. I agree with Mark in that atrial fibrillation was the precipitating factor for this event. But then if you eliminate or if you reduce the causes for that atrial fibrillation, that is the atrial overload, then possibly, and only the future and the follow-up can tell us whether we're right, most probably that would have cured also the episodes of paroxysmal atrial fibrillation. Of course, it's not just interventions. We have to remember that patients like this, we can adopt, say, a preventative rate control strategy using maybe a little bit of digoxin together with the beta blockers in order to avoid further events. And even if they get into atrial fibrillation, maybe we'll get atrial fibrillation with a lower heart rate, which won't cause any significant
What I just
issue.
noticed in this patient was the large left atrium. In that case, would you take into consideration maybe more proactive strategy, or it doesn't matter, you just simply look on the event as such?
I think regarding what to do first, the valve, the aortic valve, the mitral, solve the mitral regurgitation, I follow completely what has been said. So I should first solve the aortic stenosis and then look how the mitral regurgitation will evolve. Most likely it will decrease, and then you don't have to do anything.
I have a question to you, Joseph, and perhaps Mark can further elaborate on that, because you have produced solid evidences in the directions of how to treat patients with asymptomatic aortic stenosis, timing issues, whether going surgical or percutaneous. We have also randomized trial now going into the direction of early TAVR strategy. Shall we also comment on this? I think it is pertinent in this session.
That's a very important topic because, again, we are speaking about here a patient that had some symptoms, but actually ultimately it goes about what to do if we are facing somebody with a normal liver function and significant AS. And I think my personal view is that all, of course, depends on the risk profile of this given patient, but we have now really more robust evidence that should support or can support early intervention. I think we should be mindful about what is the source of evidence. We have basically surgical versus percutaneous. In surgical, when you look at the AVATAR trial mainly, that really managed to demonstrate mortality benefit. It took time, but it was, after 5 years, there was a clear benefit of mortality in treating this patient, low risk, lower age. When you go to the early TAVR, you have a different patient population, though similar, I would say similar degree of stenosis, but different age population. And there we see improved outcomes as regards heart failure admissions. So I think somehow we are moving to the direction of the, let's call it preemptive maybe intervention. I think it indeed may be worth to share the opinions. Is it something that makes a sense to us? Is something that we can cope with that down the road? It could be a tsunami of the interventions. And again, maybe is there any like grading in all these categories where maybe should be prioritized for a certain patient? So I don't know, what is your opinion?
I think there are two issues I want to elaborate upon it. So for example, in the early TAVR, you see that in the active treated group, the ones who got the TAVI, they have less hospitalization. So it's a very good point. We don't see any impact on survival. But what's nice to see in early TAVR that in the watchful waiting group, there are a lot of adverse events. So these patients, they don't feel well.
Yeah.
And we also know that in this asymptomatic severe aortic stenosis, it can very fast decline. The situation hemodynamic, there's a very fast hemodynamic deterioration which can cause problems. The first part of my answer. The second part is the watchful waiting approach, a preemptive one. I think it's a strategy which makes sense, but I should incorporate the staging. If you see that there is extravalvular damage, again, if we can implement that in our strategy, then I think we do a good job for these patients.
I saw Lorena nodding. Let's pull Lorena into this discussion because the valve coordinator here plays an extremely important role. Any thought on this point of the discussion?
Yeah, really interesting discussion, particularly as this patient was asymptomatic. So a lot of the discussion may revolve around her options. I agree with in terms of some sort of a scale, in terms of when to intervene, when not to intervene. But there's a lot of information, a lot of education that would need to be given to the patient that she would be able to cope with. To allow her to be involved in that decision making in terms of whether to proceed now or whether to watch and wait. I think as somebody quoted earlier, the proof will be in the pudding whenever she's had the procedure, and when she reflects back of her symptoms, be that functional, be that fatigue, pre-procedure and now post-procedure, will really show the benefits or not of the actual intervention itself, because she may due to her polymyalgia, it may have just adapted to the limited functionability when actually it may have been the cause of it may have been her aortic stenosis.
Thank you very much. Giuseppe, how about the medical treatment of this patient that poses several challenges from a heart failure perspective, from the perspective of antithrombotic therapy as well? What are your thoughts on that?
No, I think we need to treat patients. We don't treat the disease. So it's once this patient is treated, I mean, you may think it's done, but this is a patient who has had an episode of heart failure and has a preserved ejection fraction, therefore should be on an SGLT2 inhibitor and an MRA. That is a given and should be continued. We may wish to discuss on whether, if we go down the path that Mark delineated or the watchful waiting, we have to take into account also what are really the waiting list for low priority patients like this for an AFib ablation. So we have to put that into the perspective of our own centers. And if we go for a control, then probably beta blocker, low dose beta blocker with DIG probably will save us, at least give some filter for an episode of future atrial fibrillation if it occurs. A patient has had an episode of atrial fibrillation, therefore is a lifelong NOACs.
This is a passionate discussion. I would stay here for hours to debate about this kind of case, especially because there is some discrepancy in thoughts, which makes it beautiful, this kind of forum. But it's time to wrap up. These are the key learnings that we just lined down together. Aortic stenosis is often part of a complex myocardial disease process, not an isolated valve pathology. Cardiac amyloidosis, we learned that is quite common in elderly aortic stenosis patients requiring targeted screening. Interventions in severe aortic stenosis should not rely solely on symptoms, but a structured diagnostic pathways and staging yield precision in patient selection and tailored TAVI timing. And finally, optimal management in severe aortic stenosis requires integration of valve intervention, comorbidity management, and as needed, heart failure treatment. So with this, I would like to thank all the colleagues here in the studio, connected remotely. I would like to thank our fellow participants here who contributed very actively to the discussion. And stay tuned because it's coming up a very important presentation by Chiara Militello from the iHF call for submissions entitled Radiation-Induced Ischemic Heart Failure with Dual CTOs in a Young Lymphoma Survival. So it's not about pharma, it's about heart intervention cardiology procedure. Thank you very much for staying with us.
Thank you.
Thank you.
Thank you.
Thank you.
Good morning. I am Dr. Chiara Militello from Sant'Andrea Hospital in Rome. Thank you for the opportunity to present this clinical case. Radiation therapy has dramatically improved cancer survival, but it has also created a new population of young patients with complex cardiovascular disease. Today I will discuss the case of a 35-year-old lymphoma survivor presenting with STEMI and multivessel coronary artery disease, in whom prior mediastinal radiation significantly influenced our revascularization strategy. Our patient is a 35-year-old male with a BMI of 29. His cardiovascular risk profile included hyperhomocystinemia and impaired glucose tolerance. His medical history was notable for Hodgkin lymphoma at the age of 15, treated with chemotherapy and mediastinal radiotherapy with a total dose of 30 grays. Additional comorbidities included thoracic outlet syndrome, pectus excavatum, ulcerative colitis, and allergic asthma. He presented to our emergency department with acute chest pain, and the EKG showed an inferior STEMI. Laboratory testing demonstrated significant elevation of high sensitivity troponin, preserved renal function, LDL cholesterol of 145. At admission, transthoracic echocardiography was performed, showing moderately dilated left ventricle with infraposterior and basal infraseptal akinesia, with an estimated LVF of 35%. We also observed moderate to severe functional mitral regurgitation. The patient was therefore referred for urgent coronary angiography, which identified culprit lesion, an acute thrombotic occlusion of the mid-RCA. In addition, it showed 2 chronic total occlusion involving mid-LAT and the proximal left circ. Given the acute presentation, we proceeded with primary PCI of the RCA, successfully implanting 2 overlapping drug-eluting stents. During the subsequent stay in the CCU, the patient showed clinical improvement under optimized medical therapy, including intravenous nitrates and beta blockers. The course was completed by fever with positive blood cultures for Staphylococcus epidermidis. Therefore, we initiated targeted intravenous antibiotic therapy with good clinical response. At this stage, the key issue became the management of the remaining CTO lesions. The case was therefore discussed extensively within our multidisciplinary team. In a young patient with multivessel disease, CAPG might normally be considered. However, the history of radiation exposure significantly altered the risk profile due to mediastinal fibrosis, impaired wound healing, and hostile chest anatomy. Moreover, standard surgical risk scores may underestimate operative risk in radiation-exposed patients, and considering the young age of the patient, concerns regarding venous graft durability and lifetime risk of repeat sternotomy supported an initial percutaneous strategy, preserving surgical revascularization as a future option if needed. Before proceeding with intervention, cardiac magnetic resonance imaging was performed in order to evaluate myocardial viability and scar distribution. CMR demonstrated an ischemic injury pattern with myocardial edema in the mid-basal infraseptal wall, along with subendocardial LGE involving infraseptal and anteroseptal segments with localized no-reflow area in the basal septum. A transesophageal echocardiogram confirmed persistent functional moderate to severe mitral regurgitation without any evidence of infective endocarditis. Based on his findings, the art team ultimately decided to proceed with stage percutaneous revascularization. We therefore performed PCI of the LAD CTO using a dual injection approach by radial and femoral access. The lesion was successfully treated with implantation of 2 overlapping drug-eluting stents using a provisional bifurcation approach with bulky spot optimization. The final results showed excellent TIMI flow. Equally important was the optimization of guideline-directed medical therapy for heart failure. The patient was started on comprehensive quadruple therapy, including sacubitril/valsartan, beta blocker, SGLT2 inhibitor, and MRA, together with duct and high-intensity statin therapy. At follow-up reassessment, we observed clear clinical and echocardiographic improvement. The patient was asymptomatic, LVF increased to approximately 45%, and the MAR improved to mild to moderate severity. Importantly, the patient tolerated the therapy so well we were able to further up-titrate the GDMT, highlighting the importance of continuous optimization of heart failure treatment even after successful revascularization. In conclusion, this case highlights several key points. First, mediastinal irradiation may lead to premature and aggressive coronary artery disease, often decades after cancer therapy. In STEMI with multivessel disease, culprit-only PCI followed by stage-complete revascularization aligns with contemporary guideline recommendation. Multidisciplinary art in discussion is essential, as conventional risk models may underestimate the complexity of radiation-associated cardiovascular disease. Cardiac MRI plays a pivotal role in viability assessment, particularly when planning complex CTO interventions. And finally, revascularization and optimal heart failure therapy must proceed in parallel. In this patient, the combination of complete revascularization and aggressive GDMT optimization resulted in measurable recovery of left ventricular function. Thank you very much for your attention.
Welcome to the iHF meeting and especially to this session dedicated to advances in the management of heart failure beyond the 4 pillars. So for this session, I have the great chance to be with colleagues and experts. Shelley Zeroth from Canada, Gianluigi Savarese from Sweden, Bika Mbozot from US, and Alexandre Mebaza from Paris, France. So this is a disclaimer, and this session is supported by Medtronic. And here you have the disclosure of the 3 speakers. And without any other comment, I will hand over to Shelley for her presentation.
Wonderful, thank you so much. It's an absolute pleasure to be here all the way from Canada. And I think this is such an important topic, addressing really what I consider device optimization, really moving beyond the pillars. It's an opportunity for us to discuss something that's often neglected. And I'm very proud to introduce you to the concept of the DIRECT-HF program, Device Rhythm Management of Cardiac Therapy in Heart Failure. This is a global, needs-driven, patient-centered educational program. And I will show you actually some of the practical guidance that we've generated from this as part of the opinions of 16 top international experts, as well as persons with lived experience. And this, of course, is part of the global education program curriculum that has been developed. We have tackled the challenging concept of guidelines for personalized care and patient management in terms of cardiac devices. We have also talked about the appropriate use. There's been a lot of debate in the era of 4 pillars of HFrEF therapy, when to refer patients. We are talking about barriers in real life. Our surveys addressed many of those issues. And we are looking at the re-emphasizing the key role of cardiac rhythm management devices and really having a close collaboration between heart failure specialists and EP specialists and rhythm specialists. So this is really important. Again, this is an international working group, which we've had educational needs assessment, and we've developed a wonderful program curriculum that I'm going to give you a QR code to get ready to scan, so get your phones ready. These are all of the members of DIRECT-HF, but look at the number of patient associate representatives from across the world, as well as their larger associations as well. So we're very proud of this body of work, and it's chaired by Javid Butler and Cecilia Lind. Now, we started off with a healthcare survey, and we are completing a patient survey. We've done an expert consensus document. We've done global educational webinars. This is part of a further global curriculum and a website that I'm going to introduce you to here. This QR code will take you to the DIRECT-HF website, which contains useful tools for you, as well as some of the publications, which I'm going to show you. It introduces you to the members of the DIRECT-HF team, and I think you'll find this a really useful resource. So scan that QR code. I'm going to leave it up for another second here, because I think this is a wonderful knowledge translation tool for everybody who's joining us here today. So this is a wonderful document. I'm going to show you a figure from this document at the end of the presentation, so you're going to have to stay tuned for that. But this was published in the European Journal of Heart Failure. This is a consensus document about the timing and the role of optimal use of cardiac rhythm devices in our patients with HFrEF. So download this. It's a wonderful reference document for you. And I'll hand it over.
Thank you very much, Shelley, for this very comprehensive introduction about the DIRECT-HF program. So now it's my great pleasure to introduce Gianluigi Savarese. We will discuss about a very important topic, because patients with HFrEF should receive the 4 fantastic, as we call them, the 4 drugs. But also there are devices could be helpful with the medical treatment, and usually the devices are underutilized. So, Gianluigi, thank you very much.
Thank you so much, Christophe, and for the invitation being here today. So first of all, why do we still need treatments and new treatments, new interventions to be tested in patients with heart failure? Well, you can clearly see here some key epidemiological facts regarding the disease. Heart failure still represents a global pandemic with more than 60 million individuals worldwide living with the disease. And this is going to become more and more a problem over the time because the population is growing and it's aging. And of course, this leads to higher prevalence of the disease worldwide, together also, of course, to changes in comorbidities and risk profile of people at risk of heart failure. So heart failure stays a key topic in the healthcare setting. And how do we treat patients with heart failure? Well, multidisciplinary and integrated care is really the key. We see very clearly that many different healthcare providers are involved in the care of these patients, starting, of course, with heart failure specialists, electrophysiologists, but also nurses, pharmacists, general practitioners are involved in the care of these patients. Why that? The reason is that the treatment is actually a very, let's say, include different interventions. We start with medications, but then we must consider devices. But some specific patients even need surgery. Lifestyle interventions are important for all, and management and monitoring stay a key a factor for all patients. So multidisciplinary team is key. We need to start to treat this patient with medication first. You were indeed, Christophe, speaking about the 4 pillars. The 4 pillars are class 1 recommendation according all the guidelines. It's indeed what we really need to start with. But there are also some issues related to using the 4 pharmacological therapy in patients with heart failure. First of all, not all patients might tolerate all the 4 pillars or neither the target doses of this medication. So the first concept is we should really not talk about target doses, but rather the maximum tolerated doses of these medications. Why is that important? Because very often we recommend devices where optimal medical treatment is achieved, and optimal medical treatment is not target doses of all the 4 medications for all the patients. Some patients might not. So this is a first key aspect to consider when we evaluate actually an indication for a device in these patients. And indeed, as we can see in this slide, in many different registries worldwide, we clearly see that on all patients, not all patients, receive quadruple therapy at target doses. One reason is, of course, clinical inertia, but as I was reporting also earlier, many patients might indeed not tolerate target doses. And therefore, whether we wait for achieving target doses for then implanting a device, maybe we will just wait forever because these patients might never be on target doses of medication. But when should we consider devices in patients with heart failure? And here we focus on ICDs for primary prevention of sudden cardiac death and CRT. So we try to provide, first of all, in the direct HF, we try to summarize the current recommendations for actually devices in patients with heart failure. We make very clear in this figure that first of all, we need to think about optimizing medical treatment. So you see optimizing the use of ACE and ARNI, beta blockers, MRA, and SGLT2 inhibitors. Of course, loop diuretics might be needed for fluid retention. And then in order to phenotype the patient in the right way, in order to understand the right device for the right patient, we need to look, first of all, at the ejection fraction. Well, whether it's equal or lower than 35%, there is an indication for a CRT or an ICD, depending on the QRS length. So based on that, we might decide whether we might need a CRT, a CRT-D, a CRT-P, or an ICD which at the moment has different actually class of recommendation in patients with non-ischemic and ischemic heart failure, as you can see on the left in this slide. Why devices are important? Devices are important on top of pharmacological treatment, and this is very clear in this real-world study, very recent study. So we are used to say that the evidence on devices is outdated. Trials were quite old, so we really don't know if these devices are still show efficacy nowadays. But if we look at real-world data, we might see that whether patients have pharmacological treatment on board, the devices, whether is implanted, will lead to further improvement in survival and depending on the device, of course, for CRT also lower risk of heart failure hospitalization. So the key message here is, of course, start and optimize quadruple GDMT, but not forget that then you need to consider indication for ICD or CRT-P&D, and in the next few minutes we will see when. And quadruple therapy plus device therapy is class 1 recommendation in all international guidelines.
Thank you very much, Gianluigi, for this very nice talk. I think one of the key messages is that drugs and devices are not in competition, but they are combined therapy for them. So now it's my great pleasure to welcome Bike Mothers, who is online today. She was not able to join us, and she will deliver about a very important topic, and I would say a misunderstanding in the community, especially the heart failure community sometimes. It's about current pharmacological therapy as dramatically you reduce the risk of sudden arrhythmic death. But you will see that this risk is still present even with optimized medical treatment. Thank you, Bike.
On a topic that is crucial, one of the commonly quoted misconceptions, and I will try to dispel the misconception that current pharmacological therapy has dramatically reduced the risk of sudden arrhythmic death. There is a perception that the risk of sudden cardiac death in patients with heart failure with reduced EF is declining. This is partially due to the expansion of the guidelines, which now include the 4 pillars of therapy that include RAS inhibitors, SGLT2 inhibitors, beta blockers, and mineralocorticoid receptor antagonists, known to improve outcomes, and some proven to reduce sudden cardiac death and result in reversal of remodeling. Some editorials have suggested that sudden cardiac death, especially arrhythmic sudden cardiac death, is no longer a significant risk for patients with heart failure that are treated with guideline-directed medical therapies. But in this talk, I will try to underscore the importance of the residual risk of sudden cardiac death and the necessity to incorporate device therapies with ICD into the orchestration of guideline-directed therapies, which include ICD in patients with heart failure with reduced EF. Let's start with the reported trends, such as the one shown on this slide regarding the sudden cardiac death rates reported in the randomized clinical trials in heart failure. As shown on this slide, there have been reports stating that the sudden cardiac deaths are reported to decline over time in the randomized clinical trials. It should be kept in mind that in 1990, the patients enrolled in the heart failure trials were much sicker, with more advanced NYHA class, lower EF, most without ICD, and most represented higher rates of mortality. If one were to compare the trials with similar severity of illness, the trends for sudden cardiac death actually remains similar over time, as shown by the orange line. The second important point is that the residual annualized rate of sudden cardiac death risk across studies is still very high, 3.75 as shown on this slide, which is considerably higher than the 1 to 2% rate that is cited in patients with hypertrophic cardiomyopathy, most of whom have an indication for ICD. If we examine the rates, the sudden cardiac death rates reported in clinical trials as shown on the left, the residual risk of sudden cardiac death, even in the contemporary heart failure trials, remain at 2.53% per 100 patient years, which is a significant risk for death. And more importantly, the proportion of death attributed to sudden cardiac death remains 35 to 39% of all mortality in heart failure trials, despite the guideline-directed medical therapies. Even in the contemporary trials, the use of ICD is still associated with a lower risk of sudden cardiac death. As shown on this slide, in the Paradigm HF trial, ICD therapy was associated with a 56% lower risk of sudden cardiac death in patients meeting the eligibility criteria for primary prevention of ICD, irrespective of the heart failure etiology, including those individuals with ischemic or non-ischemic cardiomyopathy, even after propensity score adjustment. Recent large-scale population-based studies also demonstrate the continued benefit of ICD therapy in real-world patients, with significant reduction in sudden cardiac death rates in individuals with heart failure with reduced EF treated with contemporary guideline-directed medical therapies. Shown on the left side is the data from a large Swedish cohort of patients with heart failure with EF less than 40%, that demonstrate a 12% reduction in all-cause mortality in individuals treated with ICD compared to propensity-matched controls that are not treated with ICD. On the right side is the evidence from a large cohort from Europe of patients with ischemic cardiomyopathy and EF less than 35%, where ICD therapy was associated with a 32% reduction in all-cause mortality. And in another real-world contemporary analysis, approximately 48% of the first-time ICD recipients received appropriate therapy with either ICD shock or ATP therapy, majority of which could be life-saving, and this was seen over a follow-up of 7 years. These data underline the importance of continued benefit with ICD despite guideline-directed medical therapies in the contemporary era, and that we need to remember ICD therapy is recommended as a class 1 indication in the heart failure guidelines, and ICD therapy is part of the guideline-directed therapies in patients with reduced EF. I will now pass it on to Dr. Gianluigi Savaresi, who will talk about the timing of referral. Thank you for your attention.
Thank you so much, Bikem. We go through the next part of the presentation. Okay, so we will talk about misconception number 2. So as medications improve remodeling indices, the timing of referral for device should be reconsidered. So actually, we all agree, I think here, that actually GDMT, so pharmacological GDMT, I think that's the right term we should use because, as we say, devices are also part of the GDMT, might lead to remodeling, which in turn leads over the time probably to less patients in need of receiving a device. This has been demonstrated in few studies. Here you see, for example, the iHF trial. Patients were on sacubitril/valsartan. You see that at 6 and 12 months, remodeling happened in a number of patients, and this led to less being in need of receiving a device. And this is for sure true, and that's why we always recommend to start first with pharmacological treatments, and after 3 months consider actually a device. But are all the patients the same? Probably not, because when it comes to, for example, ICD, patients are at different risk, for example, of arrhythmias, or they have a different chance of recovering ejection fraction after initiation of pharmacological treatment. So what we are really recommending here is a more phenotyped approach to referral and implantation of devices, and of course choosing the right device for the right patient. For example, you will have patients with very high risk of ventricular arrhythmia and sudden cardiac death, and in these patients, maybe you might not need to wait that long before implanting a device and playing that much for achieving what we call target doses, and I already explained why we should not focus that much on target doses, but on maximum tolerated doses. Some patients might have so low ejection fraction that it's very unlikely that they might recover EF with pharmacological treatment, and some of them might have ischemic heart disease and such an extensive myocardial scar, which makes quite impossible to recover ejection fraction. And so in specific phenotypes of patients, probably we should even reconsider the timing for implanting a device after initiation of a pharmacological treatment for the prevention of sudden cardiac death, and therefore we speak about ICDs. And this is therefore the approach which we do recommend in the direct HF approach here reported in this slide. You see that here we have an algorithm which is more patient-centered. So we propose different algorithms for referral and for implantation of device based on the specific phenotype of the patient. In the patients with chronic heart failure initiated with pharmacological treatment, of course, as all the guidelines do, we recommend initiating pharmacological treatment waiting 3 months before referral. But in patients who are at high risk of life-threatening arrhythmia, we really do recommend not to wait that long and start directly with an immediate referral in a way that the patient is already in the right setting, whether an early implantation of the device is indeed needed. There are also patients who have arrhythmogenic cardiomyopathies. These are patients at very, very high risk of sudden cardiac death. And although these patients might have non-ischemic cardiomyopathy, these are patients who are really in need of an immediate implantation, and therefore we should not really delay referral while we are setting pharmacological treatment. And again, as I mentioned earlier, whether patients have very low ejection fraction and an extensive scar because of ischemic heart disease and revascularization is not an option, then once again we should consider an immediate implantation of the device at first line intervention. This is of course valid for ICDs, is more considering the patient and the different features that might really trigger a more phenotype-oriented approach to the referral and implantation of devices. When it comes to QRS and therefore indication for CRT, we should not really forget that patients with a left bundle branch block and very broad QRS have less likelihood of recovering ejection fraction after initiation of pharmacological treatment. So after our 3 months of pharmacological treatment, whether there is no improvement, we should not really wait long. We should really not delay implantation, because delaying implantation is associated with worse outcome. You clearly see in the study on the right, in the tarot, that whether patients stayed longer with an ejection fraction less than 35%, they were at higher risk of mortality. You clearly see that whether the implantation is delayed, this leads to a higher risk of all-cause mortality and higher risk of heart failure hospitalization. So longer you wait and you expose your patient at higher risk of outcome. We have also very recently shown this data in the Swedish Heart Failure Registry. This is a study from my group, where you can see more or less a dose-response curve between the number of months you wait before the implantation and increasing risk of heart failure hospitalization and cardiovascular mortality, whether indeed you delay the implantation of the CRT and there is an indication for the CRT. We should not forget one thing. I was speaking about the target doses and maximum tolerated doses. So as I said, some patients do not tolerate target doses. In those patients, you take a decision when you understand you can optimize more medical treatment, you implant a device. There is one reason more you should implant a CRT in this patient, and you should not delay it to try to achieve more higher dose of medical treatment. The reason is, as we show in this study from the Swedish Heart Failure Registry, that CRT itself might work as an enabler for optimizing pharmacological treatment. Of course, whether you implant a CRT in these patients who are not fully tolerant for medical treatment, you might use a remodeling, blood pressure might go a little bit up, there might be better renal perfusion, this leads to higher blood pressure. You might be able, after the implantation of CRT, to push a little bit more with optimization of medical treatment, and this is actually leads to even better outcome after the implantation of the device, this time mediated also by an improvement in use of pharmacological treatment. So these are the reasons why we really suggest a new model, as also reported in this position paper from the HFA and ERA, for integrated use of devices, wherein devices are considered early during the heart failure disease course and used in combination with drug therapy, because as we say, GDMT is not only pharmacological treatment, but pharmacological treatment plus devices.
Thank you very, very much. I mean, we heard so many great lectures. And Shelley, I'm going to start with you, because you did a great presentation to show how we are working in silo and how we really need to work together. However, if I am a heart failure specialist, I am alone in my hospital, or I am in a private practice, how do you see my interaction with EPs while I am alone, or maybe with 2 or 3 heart failure specialists? How do you see this extension and the way we can communicate? Should we meet like once a month? Should we? How do you see we can really do the best for our patients?
Yeah, I think the model is different depending on if you're community or an academic center. I have the luxury right now of my PACER clinic, where my patients get interrogated for their ICDs and CRTs right next door. So it's very convenient. So if I think that they've had symptoms, an arrhythmia, a therapy, I can get that integrated quite quickly, or interrogated, pardon me, quite quickly. I do think that the technology which allows remote interrogations is really quite remarkable, and is probably underutilized, and is probably another way in which community cardiologists can have a better connection and communication with their electrophysiology colleagues. It's challenging to have simultaneous clinics because of the implant schedules and the clinic schedules, and it gets a little complicated. I think, having somebody that you could open or reach out to regularly is important. So either the on-call person or your go-to person is really important for us to have the discussions. I think the most important discussion we should have now is about timing with our EP colleagues. Heart failure cardiologists tend to be a little slower with referral, and this is something that we really need to change. And I think Gianluigi presented some really important data to show that there is a risk. The sooner we refer, the better outcome for our patients as well. So it's personalized, just like it's a personalized approach to the patient, it's a personalized approach with that collaborative relationship with your electrophysiology colleagues.
How many patients that you see would you send to the EP? Is like 15%, 20%? And I think what people would like to know is why those patients, why not the others? What are the criteria? This will help us a lot.
Yeah, so I think that I think there's a great slide that summarizes, at the very end I'm going to show you, that summarizes. It's a great tool. It should be up in everybody's clinic, actually, because it's not just physicians that refer, it's the nurses, the nurse practitioners are identifying these patients who are on GDMT or aren't tolerating further up titration, their EF is less than 35%, and there's, I think, different urgency criteria, which and you started showing that, Gianluigi. It was great slides to think about. What percentage? Again, I think it depends on the type of clinic you have. My clinic includes patients who have advanced heart failure, are being considered for other advanced therapies like transplant and VAD down the road. So our percentage of patients who are referred for ICD and CRT optimization will potentially be higher than a community cardiologist practice that may have some HFpEF patients in it, right, as well. So they're not in the ejection fraction range for a primary prevention device. So I hate to give a percentage and let people think that they're not doing it. Any referral is a great referral. And if you're under an advanced heart failure therapies percentage, that doesn't mean you're not doing a great job.
May I completely agree what you are saying. And we should not forget that not all doctors and colleagues are working in university hospitals. Some may not have access to the IEP or the colleague implanting a device next door. And that's where I think direct HF is particularly important, because providing guidance regarding the timing for referral and implantation is important. I think we should not just consider when referring the patient, but I think it's important to consider when to start a discussion also regarding the timing for referring the patient. For example, I think nowadays all the electronic health record systems in Europe and in many, many countries worldwide facilitate the interaction between different hospitals and clinics. For example, in Sweden, we are very much used to communicate by referrals and asking to colleagues in other hospitals, well, do you think that this patient should be recommended for CRT or not? So, well, I think it's important to use the expertise of the colleagues also in the hospital next door, and whether you are not sure, basically ask for guidance. I think checking the direct HF document is important, and then if you don't have in-house the knowledge and you are not sure about referring or not because you don't want to show that you are not doing the right thing to the colleague, just like ask and go ahead.
I would say some of the referral forms are outdated as well. They haven't been updated for the last 5-10 years. The EF criteria are not in keeping with contemporary guidelines as well. Not all of us are as quite electronically linked as you are in Sweden, so there's still that reliance on paper, and so I really encourage people to go to the Direct HF website as well to get with the contemporary guidelines and update their current practices.
I think that we definitely have a need of education, not of the patient, but of the physician. Because even a country very well organized like Sweden, when you look at your registry, about 1/3 of the patient we should receive an ICD really get an ICD, even in your very well-structured country. So I think that today there is some, I would say, some misconception about ICD as well. ICD is like a very dangerous device, but now we have new devices, subcutaneous, extravascular ICD, so it's a little bit more simple with less transvenous lead. So I think that we have as a physician, we have to try to educate our colleagues. And I fully agree with you that with the new technology, we are all in academic hospitals, so it's very easy to knock at the door of our colleagues. But I think, and we try to do this in our community hospital as well, to have interaction using Zoom or other devices. But I think that we have to discuss about that. I have a question also for you, and it's very important because we have the indication and we have the guideline based on very old study, but now we have new criteria. And you show in your presentation, for example, fibrosis is important. Genetic also is important. We have a patient with non-ischemic cardiomyopathy, history of familial cardiomyopathy. Probably we have to focus on genetic testing. So is it in your clinical practice?
Oh, definitely, yes. I think the guidelines are important, but we should not forget that we are physicians and we should actually apply our knowledge. And our knowledge led to this document is like understanding the risk of sudden cardiac death, for example, is much more than only ejection fraction. It's also understanding how much fibrosis is there, understanding whether there are genetic variants which are associated with higher risk of sudden cardiac death. And this leads to familiarity as well. We should not forget to talk to our patients to understand what happened in their family in the past and so on. So phenotyping patients is considering all these aspects at the same time. And I really think, for example, nowadays in 2026, in most hospitals, you have easy access to MRI. So why don't you check for fibrosis in your patients? Also, genetic testing is becoming extremely simple to be performed. So in case there is uncertainty, if you follow our document and you understand by following our document that some categories of patients deserve a little bit different attention in specific timing on their disease, you will find actually the right action to perform at the right moment.
We have a question from the audience about a patient in whom you discover a non-ischemic cardiomyopathy with ejection fraction 25. You start the pharmacological treatment, so you expect that the LVEF will increase in a few months. So, but this patient is still at risk of sudden cardiac death. So the question is, what is your strategy during the optimization of the medical treatment?
I discuss the potential need for referral for a device at the very first visit all the time. So I let them know our job here is to put you on medications to see if there's an improvement in your heart function, evaluate your overall risk for clinical events, and if appropriate, we will refer you for the appropriate device after discussion with you. So I put it in their head early on that it's not just about medications. There may be a referral required as well. And then, depending on the patient, I most often discuss goals of care as well. So the team members have an idea, is this patient interested in an ICD referral when the time comes or not? And we always make sure we have an EKG at the first visit, which sort of guides, again, whether or not this is going to go a CRT direction or not. So I introduce it right at the beginning as a concept for something that needs to be reevaluated within a few months in the majority of patients. Sometimes we take a little bit longer, but the majority we look at it within about 3 months.
I completely agree, and in most patients, for example, we of course discuss as soon as we meet the patient the first time which kind of plan we might have for the next months. In patients where we perceive the risk might be particularly high, we perform also all those diagnostics which might allow further and better risk stratification. So once again, an MRI for understanding the extent of fibrosis, And sometimes also we perform actually a recording of the ECG over 24 hours to understand whether there are specific arrhythmia and so on. So based on these parameters, we can better stratify the risks and actually also understand how aggressive and fast we need to be with up titration in order to not keep the patients exposed to risk for so long while waiting for optimizing medical treatment.
And we have also to keep in mind that in some patients, wearable cardiodefibrillator could be also useful during the timing of this potential improvement in left ventricular ejection fraction. And so it's not a definitive device, but at least the patient is protected.
Gianluigi, you said during your lecture several times, GDMT cannot be tolerated, GDMT is maybe tolerated, we need to pay attention on toleration. What do you mean exactly by toleration? Because at least we have 4 drugs. I think we all agree that SGLT2 is
easy to tolerate.
Easy to tolerate, then already it's not all GDMT. MRA, we know it's more maybe potassium, although we know that combining the two can help. Then when we are saying, all of us, when we are saying GDMT intolerance, are we talking about beta blocker, ACE-ARNI? I mean, can you define this? Because really...
All of the above, right?
Exactly.
Yes, exactly.
People who are listening to us, they would like to know exactly when they should think intolerance.
Of course, it's blood pressure, it's renal function, it's potassium levels, it might be bradycardia with beta blockers. So all these very simple parameters that should be always checked in our patients. And we should also, we should talk to our patients, because sometimes a patient has 100 systolic blood pressure, but no symptoms. So, well, we can try to push a little bit more on medical treatment, but there are patients with 105 and they feel dizzy because of medical treatment. So it's really, there is no one approach fitting all these kind of patients. So speak with patients, of course. Measuring these important parameters is important. Some medications are better tolerated, some medications a little bit less, but it's not always we see all patients tolerating, full dose of sacubitril, valsartan, beta blockers.
We have a lot of heart failure nurses listening to us.
Right.
GDMT intolerance, is it something that can be only diagnosed by physician? Or can we have the heart failure nurses? Can you really tell us that really the heart failure nurses can do it?
I'm such a big fan of the heart failure nurse-led clinics in Sweden. I think they really run most of the show. Nurses can do as well as doctors, in my opinion, even better, for actually rapid up titration of medications, very often also understanding whether there is fluid retention and management of diuretic therapy. And therefore, in Sweden, it happens extremely often. As a doctor, I see the patient the first time, I prescribe medication to start with, I define the diagnostic algorithm I want to follow, but over the next 3 months, the entire work is just done by the nurse. So after 3 months, in most of the case, I will have from the nurse the patient on quadruple therapy with very high doses of medication.
Yeah, I would add, we have a lot of nurse-led clinics in Canada as well. They're algorithm-based, and that increases the success rate, in my opinion. But I think it's important to communicate to your EP team as well that you're referring to them because you can't up-titrate to target doses, that they're not tolerating GDMT. Because I've had some very keen colleagues push back and say, you have not maximized their MRA or their beta blocker, et cetera. So make it very clear when you're referring that that's the reason why you're doing it as well, because there's keeners out there who want us on target doses of GDMT, and you have to make it very visible. And the other thing I think we haven't really touched on during these presentations is the patient that doesn't tolerate GDMT. sometimes also has a significant burden of mitral regurgitation. Right. And so, CRT in particular reduces the burden of mitral regurgitation. And so that can be a big game changer for these patients in terms of ability to up-titrate their therapy.
When it comes to tolerability, I think we should neither forget the data I was showing regarding the role of CRT as an enabler. So after we have implanted a device, still we need to work on optimization of medical therapy, because also according to the consideration you were making regarding mitral regurgitation, the remodeling induced by the CRT can, facilitate the up-titration and improvement of GDMT in this patient.
And also we were discussing about tolerance of GDMT, but usually we see the patient in the outpatient clinic at rest. But I am a fan of exercise tests for heart failure patients, because in about 30% of them, you can find a atrial chronotropic intolerance. And these patients, they have an improvement in left ventricular ejection fraction, they have a good blood pressure, but they are still complaining of limitation of exercise. It's just because the heart rate increased from 50 to 60, 65, and they are totally blocked there.
Right.
And this device also can be very helpful, because you can program a device with response algorithm, and so they will increase the heart rate during exercise up to 120, 130, that depends on the programming. So I think also the tolerance should be assessed at rest, but also during exercise.
Completely agree.
Yeah, and I just want to add, the direct HF program is, is partly clinicians, but also patients. The clinicians, we tend to focus on events and sudden cardiac death reduction. The patients focus on an improvement in functional status with CRT referral, right? And so I introduced that very early on as well when I'm talking about a potential referral, because that's important in the shared decision-making process.
I would like to echo what you said, Shirley, and coming back to your first slides, you insisted on patient representative in the direct HF program. Can you tell us what really it brought in the program, and how the interaction with the patient representative really changed a little bit our vision as a physician, as nurses also, on the program?
Well, I think it gave us an important perspectives in terms of the language that we use when discussing device referral, when discussing their heart function in particular, and some, I think, more simplicity in terms of the algorithm as well. The algorithm's actually, in my mind, understandable to patients as well, in terms of the urgency of referral, the technical considerations, and then a really important, at the end of it, is the patient helps decide what device is appropriate for them. So we check all the boxes. They understand the journey that they're going on in terms of consideration of an appropriate device referral, and their optimization of their 4 pillars as well. So it was a really interesting exercise. One of my Canadian colleagues, Mark Baines, was part of this group. He's a person with lived experience and has started the Heart Life Foundation in Canada as well. And he's become an expert in heart failure and discussing heart function therapies over the last 10 years or so. So his insight has been really quite valuable.
Yes, coming back to the importance of the patient, I think we all agree about that. It was a very important part, as mentioned by Shirley, in the direct HF program, because each time I discuss with patients, I learn a lot, because sometimes my speech is a little bit too scientific. And also, we will provide you in a few months a manuscript about the patient survey. And I think it's very, very important, because for me to implant an ICD could take 30 minutes and that's it. But for the patient, he will have the device all his life. And it's something new for him. And I think that it's very important, and it was a value of the Direct iHF program to have all these patients with us.
Yeah, we also had women represented as well. And I think this, for me, is really important because women in general are less likely to receive appropriate heart failure care. And that includes the 4 pillars, but they're less likely to be referred for appropriate device referral too. So I think having their voice at the table as well will hopefully ignite an initiation for more referral for women.
Yeah, and especially we know that also women sometimes are less keen to receive ICD, for example, for aesthetic reason, we can understand. And also to discuss with them now, we can explain them that we have more discrete device, not in the subclavian area. So I think in something that it changed totally now the rate of acceptance in my clinical practice for women to accept an ICD now with the new device.
Have you been checking that? Have you been following that to see if you're increasing the...
Yeah. Some of them were...
We should be publishing this because it's so... And I think maybe perhaps even some community cardiologists don't know that there's been like a transition to subcutaneous devices which will increase the acceptance for women as well.
Absolutely. Shirley, you talked about 3 months. You said, one of your examples, you said, I talked with the patient when the patient has a criteria of CRT. I start GDMT, but I already tell him, and in our paper it's written 3 months. Can you elaborate about those 3 months? Because I hear many.
It's hard.
Exactly, I hear many specialists saying, but why 3 months? Or I mean, you see, I mean, it's important that all of us here we explain why did we choose 3 months.
Why did we choose 3 months? I mean, right? In real life, it's hard to get a patient optimized in 3 months, I think. I know you did the strong HF and you did it so fast.
Daily life.
But in real world practice, it's a little more challenging, except maybe in Sweden, right? The gold standard of heart failure care. You know, getting the message out there to clinicians is going to be important, that this is sort of a change in practice and recommendations. I don't think it's out there. I think people are still thinking 9 months, 12 months for non-ischemic patients. And this has really been a change that needs to be messaged to many clinicians.
I think the answer for me is simple. It was because it was required in the clinical trials.
Exactly.
Somebody put 3 months. If it was 6, it will be 6. And now for the guidelines, they use the criteria of the clinical trial. But I fully agree with you, and it was shown by David Denker in the Protect iHF study using wearable cardiodefibrillator that sometimes some patients are slow responders, I would say. Some of them, they need 6 months or 9 months to increase their left ventricular ejection fraction. But I like one of your slides, Gianluigi, about left bundle branch block patients. And for this patient, I think that if you have a true left bundle branch block patient, don't wait to implant a CRT. The device will not do anything about the left bundle branch block.
And that's a new message for clinicians as well to hear, right? It's always been this wait culture with the heart function teams, and we're really moving that needle closer to like 3 months or right away in somebody with a wide left bundle. Why are you waiting? I think the data you showed was wonderful.
Completely agree. And in those patients, I think we should really prioritize referral and implantation, and also probably be more aggressive from the beginning with initiation therapies, already considering that probably the therapy will not improve so much ejection fraction. So I think it's a key take-home message. Yeah.
And again, by explaining why we are referring so early, because we already start GDMT and would like quickly to up-titrate, and we need to have this being resolved. Yeah. Very good message.
So I think time is running, so now I will give the floor now to Shirley to give us some key learnings and evaluation. So thank you.
Yeah, so on behalf of the Direct HF program, we are very pleased with the global educational content that we've created. This consensus document from the group of global experts This figure, I think, should be posted in every heart function clinic, every community cardiologist clinic as well, with regards to the phenotyping of the patient, as Gianluigi spoke to earlier, with regards to ejection fraction, width of QRS, as well as additional features such as genetic testing, high burden of scarring, et cetera. That really defines the type of device that needs to be considered. But you can see here, and as we mentioned during our discussion as well, that either an immediate referral is required in those patients with a very high risk profile, or an urgent referral within about 3 months based on clinical trial protocols. So we're really changing the timing. Remember, in a patient with a very wide left bundle, don't delay referral for CRT, and that we discussed some really important myths that we have to bust within the heart failure community as well with regards to the urgency for device referral. Remember, we're not competing with GDMT here, right? These are complementary therapies that can improve the clinical outcomes of your patient as well as the functional status of your patients, especially those who are getting CRT devices. So it's all about personalized timing. And if you go to the consensus expert document or go to the Direct-HF website, which I'm going to show you next on a QR code here, you will in fact have the opportunity to get access to that paper as well. So on behalf of Professor Mabaza, Savaresi, and Leclerc, thank you so much for joining us. Any last words at all, Alec?
I think what we learned is really that we need to work stop working in silo and really having the patient benefit from all this expertise, and just love this session. Thank you so much.
Gianluigi?
My take-home message is GDMT is not only pharmacological treatment. Don't really forget that it's pharmacological treatment plus device.
And mine is that referral doesn't mean systematic implantation, but I think it's important that the EP sees the patient first. So don't forget that EP exists for heart failure as well.
Right. Don't forget, don't delay. Thank you so much on behalf of the Direct-HF team. And thank you to Medtronic for sponsoring this session.
Good morning, everyone. I'm Dr. Ausillo from Sant'Andrea Hospital in Rome. Today I will present a case of complex revascularization in severe ischemic heart failure with reduced ejection fraction, managed with the Impella-protected high-risk PCI and rotational atherectomy. Our patient is an 80-year-old man with multiple cardiovascular comorbidities, including arterial hypertension, diabetes, end-stage renal disease on chronic hemodialysis, and ischemic heart failure with reduced ejection fraction. In particular, he had a previous hospitalization for non-ST elevation ACS, where coronary angiography showed severe stenosis of LAD and RCA, treated with coronary artery bypass graft with left internal mammary artery on LAD. During a hemodialysis session, he suffered a cardiac arrest due to ventricular fibrillation, which was successfully treated with external defibrillation. After resuscitation, he was disoriented and poorly cooperative, but initially hemodynamically stable. The EKG showed sinus rhythm at 95 beats per minute, with Q waves in V1 and V2, and mild ST segment elevation. In the emergency department, a transthoracic echocardiogram showed a dilated left ventricle with severely reduced systolic function, with an ejection fraction of about 25%. Regional wall motion abnormalities were present, with akinesia of the apex, anterolateral wall, and mid-apical interventricular septum, associated with moderate to severe functional mitral regurgitation. Laboratory tests showed severe anemia, hyperkalemia, and markedly elevated high-sensitivity troponin I. The patient was admitted to the cardiology ward, where he underwent hemodialysis, blood transfusion, and an optimization of the medical therapy. During the night, he experienced another cardiac arrest due to polymorphic ventricular tachycardia degenerating into ventricular fibrillation, successfully treated with immediate CPR and a DC shock. Then we decided to perform an urgent coronary angiography. The angiography showed a severe multivessel coronary artery disease with a subocclusive ostial stenosis of the left anterior descending artery. The circumflex artery was heavily calcified and atheromatous and showed 2 intermediate lesions, while the right coronary artery had a significant paraostial stenosis of 80% with pressure damping and an additional subocclusive stenosis in the proximal segment. Furthermore, as we can see, the graft to mid-distal LAD had a subocclusive stenosis at the anastomotic site. During the procedure, multiple attempts to cross the LAD lesion failed due to the severe calcification, highlighting the complexity of this case. After the initial unsuccessful attempt, careful pre-procedural planning was performed before a second PCI attempt. In this setting, we decided to use impella support due to the severe left ventricular dysfunction to maintain hemodynamic stability, while rotational atherectomy was required to adequately treat the heavily calcified lesion. So we decided to use a secondary access on the femoral artery. In particular, we gained an ultrasound-guided vascular access, right and left femoral arteries, left femoral vein, and left radial artery. Impella CP was inserted via right transfemoral approach and positioned in the left ventricle to provide hemodynamic support, and due to the inability to cross the lesion on the LAD, a rotawire was positioned in the diagonal branch, and rotational atherectomy of the LAD ostium was performed using a 1.25 mm bar. By doing so, it was possible to predilate with a 2.5 mm balloon and implant a drug-eluting stent at the ostial LAD, and afterwards we predilated the graft anastomosis with a balloon and implanted another drug-eluting stent. Following the first PCI, we observed an improvement in the left ventricular function with an increasing of ejection fraction from 25% to 40% and a reduction of the severity of mitral regurgitation. After 3 days, once the patient stabilized, completion PCI of the right coronary artery was performed with implantation of a drug-eluting stent in the mid-proximal segment. So, the take-home messages of this case are that pre-procedural planning is essential. In fact, the assessment of anatomy, ventricular function, hemodynamics, and the access is the key to safely achieving complete revascularization in severe ischemic heart failure. Mechanical support improves safety in high-risk cases. Impella helps maintain perfusion during hemodynamically demanding steps, enabling more complete and stable revascularization in patients with severe left ventricular dysfunction or electrical instability. Plaque modification is crucial for calcified lesion. Rotational atherectomy ensures adequate lesion preparation, improving stent delivery, stent expansion, and long-term outcomes. Stage PCI can enhance recovery. Staging procedures allow stabilization after the first intervention and supports safer completion revascularization. And a multidisciplinary approach strengthens the outcome. Input from interventional imaging and critical care teams improves decision-making in complex and high-risk PCI cases. Thanks for your attention.
Dear colleagues, welcome to this session, iHF session on mitral regurgitation, finding the right time for the right patient. How soon is now? And we'll disclose what's behind this title in the course of the session. What are the objectives? To define guideline-directed medical therapy in the setting of heart failure with reduced ejection fraction and secondary mitral regurgitation, to recognize key hemodynamics in mitral regurgitation and how they can be modified by therapy, and to explore the role of percutaneous intervention as an enabler for GDMT. But let me introduce you the team. Here with me, my co-chair, Sabine Bleitziefer, cardiac surgeon from Germany. In the studio, we still have Stefan Anker from Germany, Michael Bohm, guess where, from Germany as well. It's not enough. We still have other Germans with us connected remotely. I will start from the center, Philipp Lurz from Mainz in Germany. Yet we go to Switzerland with Julie Bruno and to Kazakhstan with Amina Rakisheva. Welcome all.
Thank you.
I think it's important to remind our colleagues that this is not just a session where they can passively follow, right? What is their duty? Shall we give them some homeworks to be done?
Yes, of course. It's very important that you all pose us some questions, which we aim to answer, of course, during the course of the session. Everybody who is listening, please type all your questions in the group chat.
Thank you very much. So why don't we kick off, Julie, and you can introduce us with the case you selected in Bern.
Yes, thank you, Emanuele. Good afternoon to all. My name is Julie Bruno. I'm a heart failure cardiologist at the University Hospital of Bern in Switzerland. And it's my pleasure to share with you this case today. These are my conflict of interest. So the case is about a 62-year-old male patient without a significant medical history in the past, and dyslipidemia, arterial hypertension, and prediabetes as comorbidities. In November 2024, the patient presented in an outpatient setting with a progressive dyspnea, NIA 3, and a diagnosis of heart failure with reduced ejection fraction was made. On clinical examination, the patient presented with signs of congestion. It was hypotensive and with a normal heart rate in sinus rhythms. And in the laboratory test, you can appreciate it an elevated NT-proBNP with a kidney dysfunction and a mild hyperkalemia. Based on these findings, a low dose of heart failure guideline medical therapy was initiated with an ARNI 50 milligram twice a day, a metoprolol 25 milligram twice a day, an SGLT2 inhibitor, and oral loop diuretic therapy with furosemide. In the following weeks, we can we have the video for the chloro maybe? I can have it work. Okay, sorry. In the following weeks, additional diagnostic workup was performed to investigate the underlying cause of heart failure. And as you can see, the coronary angiography show no significant coronary artery disease, and a cardiac magnetic resonance revealed only a septal late gadolinium enhancement. And taking these findings together, a diagnosis of non-ischemic dilated cardiomyopathy was made. During the subsequent weeks, till 2 to 3 months, the medical therapy remained unchanged, as it was considered difficult to further uptitrate it. And given the persistently reduced ejection fraction, the patient underwent the implantation of a defibrillator in primary prevention. A few weeks later, the patient presented again to the medical attention in a peripheral hospital due to an acute worsening of the dyspnea, now classified as NIA class 4, and required hospitalization. At admission, the patient was hypotensive with a systolic blood pressure of 80, still normocardic in sinus rhythmus with an narrow QRS, and saw signs of congestion with a very high NT-proBNP at this time, a worsening kidney function with a GFR of 25, and a moderate hyperkalemia. A transthoracic echo confirmed actually the known severe LV function with a severely dilated left ventricle, and reveal at this time point severe mitral regurgitation with this central jet. Our colleague started diuretic therapy intravenous this time with furosemide 40 milligram 3 a day. But in the context of hypotension, hyperkalemia, the worsening kidney function, and the very high NT-proBNP, further optimization of the GDMT was not feasible. And due to the fact that the patient didn't show a clinical improvement with this therapy, it was referred to our Center for Further Management.
Thank you very much, Julie. Just to summarize, before kicking off with the discussion, I was taking some notes. We are dealing with a young patient, 62-year-old, with heart failure with reduced ejection fraction, 20% ejection fraction at the echo at the presentation, on the basis of idiopathic dilated cardiomyopathy. The diagnostic workup that was performed in the initial hospital was coronary angiogram, transthoracic echocardiography, CMR. The patient was treated in the referring hospital with a little bit of sacubitril valsartan, a little bit of beta blocker, SGLT2 inhibitor, and loop diuretic, and an ICD was implanted in primary prevention. So that's the onset. But despite this treatment, in just 2 months, the clinical conditions deteriorated, and this patient came now in acute decompensated heart failure, near class 4, further hypotensive. ProBNP was 4 times as much as it was 2 months before. Now the question is why? Before handing over to the colleagues and trying to address this question, I remind what has been just said by Sabine in the beginning. Post a little sentence and tell us whether you would have done something different from what has been done so far. Just share with us your opinion. Now, let's start from Amina. I would like to ask you the following questions. Did we miss anything in the diagnostic evaluation of this patient? Would you have done something different in the initial pharmacologic strategy or management strategy in this patient?
Thank you very much, Emanuele, and thank you very much, Julie, for a great presentation and great case. Well, in this case, I would think of still using of MRAs. I understand that we do, as a part of GDMT, we really need to improve the outcomes, also the MRAs. And in this matter, I understand that probably the reason for excluding them or avoiding them, it's better to say, is their creatinine level and eGFR and also potassium level. Therefore, I mean, currently the hyperkalemia now, it's of course, it's something that make us to consider maybe avoidance of our MRAs, but still we do really need them to improve outcomes in heart failure patients.
That's a good point, Amina. Let me now move to the practice of Michael. How would you have managed this patient initially if he was presenting to your practice?
So Jolie has presented an indeed very complicated case because the systolic blood pressure below 100 and the heart rate above 75, and this patient had 80, has a twice as high mortality rate in the following year, because these are the main predictors of poor outcome. So looking at medical therapy, I could echo what Amina has said. MRIs are lacking. Maybe one should give them a try. Avoiding hyperkalemia is a little bit done with SGLT2 and also with the ARNI, which reduces in the long run the ARNI, but we have the potassium binders. Concerning the blood pressure, we have a recommendation from the Heart Failure Association that the profiling of the patient should involve blood pressure and heart rate. So in this case, heart rate should be brought down and then blood pressure hopefully elevates. And this can be done with a combination of the low-dose beta blocker. It's a low-dose beta blocker which is in there, and ivabradine. Ivabradine has no effect on blood pressure. Statistically, it increases blood pressure according to SHIFT trial and also to a subpopulation with ejection fraction below 25, which is the case in this case, a patient as well. And then we might get into a better window. So, of course, we have seen mitral incompetence, and therefore one should do something about that. But before that, it's a good reason to stabilize the therapy and to get rid of the residual edemas. If there is a better heart rate and blood pressure, we might get rid of the peripheral edema, which is, of course, a predictor of death in the following year, in particular when patients undergo an intervention. And then we have to discuss also if it is successful getting rid of the mitral incompetence, that it might be easier to implement more therapies, and they are working in the long run. Right.
That's a very good point. Let me involve Stefan in this discussion. We often hear that GDMT fails. Is it a true failure of GDMT in this case, or did we fail to correctly implement GDMT as it should?
Yeah, well, thank you so much. I mean, this is an interesting case where exactly this question is pertinent. I think guideline-directed medical therapy, there's so much evidence, it doesn't fail, it works. It's the question of finding the right patient with the right dose and the right combination of drugs. I'd like to echo the issue of potassium binders. We found in the Diamond trial that people with hyperkalemia, people with a fear of hyperkalemia by the physicians not receiving an MRA, that basically we were able to have 80% of patients actually on an MRA despite this kind of situation with the help of a potassium binder. Now, of course, I personally also like ivabradine. One question to Michael. Is there any beta blocker that you prefer over others for avoiding hypotension? I mean, maybe it's the wrong beta blocker?
I wouldn't say it's the wrong one. I mean, we have these peripheral vasodilatation with carvedilol, and we have it not with bisoprolol or metoprolol. So these might be the right beta blockers. However, looking at the combination enabling a higher dose of a beta blocker, these small studies, one from Spain, one from Italy, have been done with carvedilol indeed. So I think I would not switch the beta blocker because it just takes time. I would just add ivabradine. Maybe starting even with 5 milligrams, not the very low dose, and then looking what happens. There are data that within 6 months, there is a higher dose achievable for the beta blocker on ivabradine. Also, ejection fraction after a while goes up again. And another issue is if we have done that, we should look at 3 months, whether ejection fraction has improved and MI has improved. I don't expect it at that ejection fraction, but at least we should give him a try.
Is that kind of patient a classical patient for digitoxin?
Digitoxin, not digoxin, due to kidney disease. That is very important. It could be the case. We have to not finally discuss it, but in the DIGIT trial, there is an improvement of death. And indeed, it is not dependent on kidney function. It might not be dependent, or it might not increase potassium. It's a good idea. It's depending on the temperament of the physicians, but I would maybe do that.
These are a great point of discussion. You nicely alluded to the importance of these mitral regurgitation, and I would like to pull into the discussion both Philippe and Sabine. Is this mitral regurgitation of a concern, and what are the options, intervention options? Philippe first, and then Sabine.
We do know about the detrimental effects of significant mitral regurgitation in these patients, and we now have also very safe or even overwhelmingly safe signal from transcatheter edge-to-edge therapy in these patients. We have different devices We have very good imaging these days. We understand how to perform these procedures in a safe manner. And as you will hear a little bit later on, there's also a very robust body of evidence that treating MR in these patients can be highly effective and conveys a huge benefit for these patients. And very recent, we also have other technologies, devices which do not only allow repair but also replacement, so transcatheter mitral valve replacement technologies. Still early days, but again, from the data we have so far, very promising signals.
Sabine, is this a good surgical candidate?
So indeed, this is a patient who could be discussed in the heart team because he is quite young with 62 years. And depending on his clinical decision, the question surgery versus intervention could be discussed, especially if the anatomy would not be eligible for a TEER. And if we would aim for a predictable result with 0 MR in the end. So these are the things that could be discussed. But of course, without coronary artery disease, so without the option for revascularization, it's only a weak 2B indication in the guidelines.
I sense that there is some consensus here on M-tier for this patient. Also, the cardiac surgeon seems to agree, at least I understood so. To Stefan, we ask what is the science behind this technique? What is the support we get from data? Stefan.
Yeah, thank you so much. I'm really have the pleasure here to review a little bit the trial data, but I would also like then for the later discussion to point out that there's degrees of severity, and we have different words for the degrees of severity: severe, moderate to severe, less than severe, moderate, mild. Other people call it significant and non-significant. And so we need to clarify maybe then also in the later discussion how we really best use this. There's European criteria, American criteria. And of course, many of these things are ERA-based, and we have seen here also some data on this, and it was actually a transthoracic echo. But it's very important that ERA also has a three-dimensional kind of issue about it, and that's best assessed actually in the transesophageal echo. The guidelines do give it a class 2 recommendation on top then of the guideline recommended foundational therapies. The global guidelines published last year actually say for the 4+ patients, it's a strong recommendation, class 1A equivalent in this setting. And for 3+ patients, it's a suggested class 2 recommendation if you have functional mitral regurg. Now, what do the data say? Observational, big cohorts, you see a reduction in hospitalization, and this is present regardless of whether you have really more severe, mild, moderate to severe, or actually even moderate functional MR. It is possible even in milder degrees, but this patient had a severe degree. Now, the first randomized control trial was the MITRA-FR study. It showed, when it was published in 2018, a neutral result. And I would like to emphasize it had a 23% mortality at 12 months. A little later, then the 2 years results were shown also neutral. Well, then came the co-op study. Again, I would like to point out the control group had a 23% mortality at 12 months, meaning these two studies had similar mortality, but still they had different characteristics. There, completely different result. The all-cause mortality was more than 35% reduced, highly significant. The original primary endpoint was actually the reduction in heart failure hospitalizations, more than 45% reduced, very significant results. And now most recently, and we included 3+ and 4+ patients, we published the ReShape-HF2 trial, 500 patients included there, randomized and followed for 2 years, 2 M-tier versus control. And basically these patients were well treated, probably amongst these 3 big trials, the best treated patients, very similar to also what this patient received, except we also had them on MRAs. Actually, beta blockers, SGLT2 inhibitors were new. They were a little bit less often used. Look at the ERA. In our trial, 0.23, many people would say that's moderate functional MR, but please remember the core lab actually had the available data also for the transesophageal echo, and so they really classified them as 3+ and 4+ patients. In co-op and MITRA-FR, much higher ERA values, otherwise similar for age, about 70 years, similar for NT-BNP, 3,000 to 4,000. This patient here had more than 5,000. Now, when the intervention is done with MTR, you really get very fast in many, many patients, not necessarily a 0 MR, but 1+ you get in more than 70% of patients when they are 3+ to start with. Coming to the results of the ReShape-HF2 trial, you can see here on the left and the right the key events endpoint, heart failure hospitalization, 41% reduced, a composite of heart failure hospitalization plus cardiovascular death, 36% reduced, and also the quality of life. And we shouldn't forget this. With all these treatments for MTR actually improves the quality of life of patients. Now, what about the subgroups? Is there a particular group that benefits better? Well, you might say the more severe patients gradually got a little bit better, but statistically speaking, there was no significant difference between 4+ and 3+ patients. ERA made no difference whatsoever. Also, the left ventricular and diastolic volume, no difference. The last thing, and I'm actually personally quite proud, my son actually published this meta-analysis recently then for these trials, and he showed overall a reduction of event rates quite successfully, more than 30% for heart failure hospitalizations, or the composite then almost 30%. Mortality, not quite, but 24% reduction at 2 years, p-value 0.056. So I think this is something that we really, from a trial evidence base, should really consider for such a patient. And let me just conclude that patients with severe functional MR, I think the trials are now very clear, they should receive MTR. And when they have less than severe kind of functional MR, I think it's very reasonable to consider it. Maybe some more data is still of need. Thank you so much.
Thank you very much, Stefan, for this very clear and crystal overview. So we have 3 randomized trials: MITRA-FR neutral, co-opt, and ReShape positive, both of them. But looking carefully at the trial, it is clear that patient selection is key. And most importantly, we should make sure that the mitral regurgitation has a meaningful hemodynamic impact over and beyond the underlying cardiomyopathy in order to make sure that patients would benefit the most from MTR. Now, the question goes to Michael. What is the message you've got from these 3 trials, and translating the messages to the clinical practice? When you get proposed by your colleagues a patient for MTR, what are the determinants, the key clinical variables you look at in order to make sure that it's not too late in offering MTR to these patients?
That is a tricky question. First of all, if it's technically feasible, then it should be principally done because we have the majority of patients benefiting. We have used the co-opt criteria so that there is maybe a certain degree of ventricular dilatation, that the patients are beyond the point when they benefit. But now we have some data that showing that maybe not the hard clinical endpoint, Stefan, but also the patient-related endpoints such as exercise tolerance and quality of life is improved in those patients. So it is very hard to exclude these patients. And let's say we can reduce MI, and then we have the possibility in a more stable patient to better implement guideline-directed medications. So then the benefit is there in the long run, which is a secondary effect of mitral regurgitation and its correction. So it's very hard to exclude everybody. It's, of course, an individual decision. Also, it requires a consent with the patient. And one has to, I think, openly discuss with him what the chances are and what maybe there is also a certain degree of not improving the patients, but it should be openly discussed.
Now to Amina, I would like to ask the following question. If there is a point of contact within co-opt and ReShape Heart Failure 2, is the fact that in both trials, the investigators, and Stefan will correct me if I'm wrong, did their best to optimize GDMT and then consider these patients for MTR. What is your guess on this specific topic?
Thank you, Emanuele. Well, in my opinion, GDMT is crucial. And why it's so crucial, I think we need to refer to one of the nice studies, actually meta-analysis that was published in Lancet 2020 and also further 2022 was published by Muthu Vaduganathan and also and his team and his colleagues about fundamentally changed how we think about heart failure treatment. And actually, when we are talking about heart failure treatment, we're talking about percentage, 20-30% of reduction. But now in this meta-analysis, he spoke about time. So this comprehensive therapy that he showed in the meta-analysis does not just reduce events, it improved up to 6 to 7 additional years free of a heart failure events. So we're talking about free survival. That is a really magnitude benefit comparable to oncology treatment. Importantly, these benefits are additive and time dependent. So actually, it's every delay in initiation of DDMT results in irreversible loss of survival. So therefore, all these pillars, 4 pillars in DDMT gives us an opportunity to improve outcome and also gives us a time. So I think this is one of the major impact of how the DDMT improve the outcomes and also especially in patients who are going further to M-tier. So this is my guess.
Thank you very much. I'd like to go back to Stefan and get the opportunity to have you here and get some more insight into ReShape-HF2 trial. In your opinion, what has been really the key determinant in the clinical outcome improvement of this patient? Was it truly the M-tier in itself, or was it the M-tier as an enabler to GDMT optimization further? What was, according to, what had most weight there?
If I have to guess, this is difficult, of course, to discern in a precise statistical way in the trials. But because we already had good treatment to start with, the major difference was actually the M-tier. I think we had a very good interprocedural success of reducing the MR. I should also say, very important is that we had a feedback to the physicians that did the procedures from the core lab, how they were actually doing. And we actually even had 2 or 3 cases where the core lab experts, Stefan von Bardeleben is not only an echocardiography expert and he ran the core lab, but everybody knows he's also fantastic as an interventionalist. He actually went there. So with the learnings from the trial core lab, he went to the centers and did additional teaching for the FMR because sites have different degrees of experience. And this is also something we need to talk about. It's like with surgery, interventional work, and Philip probably can much more than definitely me attest to this. Experience makes a difference in these procedures. And we should not also forget that the devices, and we used in ReShape 4 different generations of devices, they have become better and better, and shall we say not easy, but easier to use. And so I think this is now very much supported by good device technology and of hopefully, at least in ReShape, I believe, good work of the people. And the last point then, not in few cases, but in many cases. We had only like 20 sites actively enrolling in ReShape. So we had a median number of about 15 patients recruited in each site active, not just 2 or 3, 15. And so this gives a higher volume for sites.
Let me be a bit controversial here, and I'd like to hear the opinion of the cardiac surgeon. Apparently, even if we reach a sort of suboptimal result, as you would see it from a surgical point of view, where the residual MR class 2, class 1, still clinical outcome improves, while you highlighted the importance of reaching MR 0 at the end of the procedure. I mean, what is your guess from a surgical perspective? How comes that the data are good despite suboptimal final MR result?
Of course, improvement of the MR is better than no improvement, but I think this is a continuum, and there is a lot of data that the clinical benefit relies on how much you can reduce the MR. So
it's the delta is important as well.
Yes.
Okay. Philippe, you were called into the discussion here by Stefan. concerning the mitral valve interventions to you. Well, of course, you can further elaborate on what Stefano just said, but we discussed with Michael how late is late. With you, I'd like to know how soon is soon. In other terms, we saw from Reshape HF2 that they could see some meaningful clinical impact even in patients with less than severe mitral regurgitation. Is there room for improvement there as well?
Yeah, thank you very much for that question. I think that sometimes we're a little bit obsessed with futility, but we forget that we shouldn't leave out the question of maybe we should treat sometimes a little bit earlier where we can gain even more. And earlier means in that context maybe two different things. The one thing is the severity about MR. Stefan already said that it's not that straightforward. It depends on different guidelines, different terminology, but also the methodology, whether it's transthoracic or whether it's TEE. And I think the key here is that whenever you think that a patient would have HFrEF and functional mitral regurgitation, which to you as a physician appears to be significant, do not stick to a single number. If it might not be that high on transthoracic, do a transesophageal echo, do a planimetric ERA, and you will always find higher numbers. There's also some patients in whom at rest MR might be only moderate to severe, but when you do stress testing, you will see that MR goes up quite dramatically and is then very, very high with high ERAs in these patients. So in the end, I'd still like the term, although it's a little bit, it's less defined, the term of significant MR. It comes down to your assessment of whether you think it contributes to the overall condition of the patient. And then the other question about early treatment is also how soon will you treat and how many trials of GDMT optimization do you think is reasonable? Because we also know that these patients should be treated very early on. We have highlighted already the importance of optimizing GDMT. If you think that the patient is frail and GDMT optimization might not work, then it makes perfect sense probably to treat early with TEER and to allow then GDMT. That's also another approach of how to think about early TEER treatment.
Thank you very much, Philippe. Before going to Bern again and see the resolution of the case, Stefan, let's clarify then the issue, because from what I listened from you, from Philippe, from the other colleagues, is that we should, in a way, try to stress out this mitral regurgitation in order to truly understand how severe that is. We even understood the importance of doing some stress echo in order to make sure that this mitral regurg is not more severe than it looks like. Final word on the diagnostic assessment. What would you recommend in this regard?
Well, if you don't have a straightforward case and you still are in doubt after the transthoracic, go for the transesophageal echo. That would be my key message. And otherwise, trust your clinical assessment and the case with 5,000 NT-BNP on guideline-directed medical therapy. Did we not learn in medicals? Frequent things are frequent. And if you have such a case with functional MR, then probably the functional MR is a problem.
That's clear enough. Thank you very much. Julie, tell us, how did it end up, this case?
Thank you. So just to remind you, the patient was transferred to our center in the setting of acute heart failure with no clinical improvement. And at this time point, we did two things. One side, we intensified the diuretic therapy using a higher dose of intravenous loop diuretic, and we also added another diuretic. And although this modification, we couldn't achieve a negative fluid balance at this moment. On the other side, we complete the investigation, particularly doing a transesophageal echocardiography that was to assess and evaluate the severity of the regurgitation, but very importantly also to assess the morphology of the valve, that in this case was normal with just a little indentation of the anterior leaflet, not so relevant, and the mechanism underlying the mitral regurgitation was a tethering of the leaflets. Due to the fact that we couldn't achieve the euvolemia, and for all these other aspects that we saw previous, we decided to go for edge-to-edge repair of the mitral regurgitation. The intervention was successful and uncomplicated. We could implant 2 clips with a reduction of the regurgitation to a mild degree and without significant stenosis at the end of the procedure. From an hemodynamic point of view, you can see that with a severe mitral regurgitation, you have actually 3 points. First of all, reverse systolic pulmonary venous flow, a low cardiac output, and high pulmonary pressure. When you perform the correction of the mitral regurgitation, you can appreciate it that the pulmonary venous flow normalized with a positive S and D wave. In addition, you have a higher cardiac output that you can measure with a higher VTI, and a reduction of the pulmonary pressure with a decrease of the tricuspid regurgitation gradient. And these changes are actually immediately visible also at monitor, where the systolic blood pressure increased from 80 to 115. And parallel, you also can appreciate it, a reduction of the central venous pressure. These improvements were sustained in the following days, and we were finally able to easier decongest the patient with then the progressive reduction of the diuretic therapy, as also the uptitration of the GMT almost at target dose. We then see the patient at a 6-month follow-up, where we can appreciate it, improvement of the functional class at the moment near 2, and a reduction of the NT-proBNP at the moment at 300. The GDMT was at target dose, and we also had a very good improvement of the peak VO2 max that led this patient at this moment far away from the scenario of advanced heart failure therapy, still a possible scenario in this case, and this is why we decided to see the patient in a close follow-up. Here you can see the echo finding, and at 6 months we had a stable result of our intervention with just mild rest regurgitation. And the LV function was still severely impaired, but just visible, you can appreciate it, positive remodeling with a reduction of the diameter of the left ventricle. And this was my case. Thank you very much for your attention.
Thank you very much, Jolie, for this great case presentation with, I would say, a significant reduction of mitral regurgitation and really an impressive clinical benefit through the uptitration of GDMT. And next, I would like to invite Philip to share his thoughts on the new frontiers of mitral TEER as GDMT enabler. Philip.
Thank you very much, Sabine. So we heard already from Stefan about the very, very solid body of evidence that treating MR by TEER conveys a lot of benefits for these patients. But if you're more skeptical, you could also argue, why is it helpful at all? Because obviously the ventricle is not the problem, is the problem, not the mitral valve per se. So why should we treat these patients at all? Well, one of the basic principles of heart failure therapy amongst these 6 is most importantly the unloading. And unloading can be done pharmacologically, but it can also be done obviously by reducing MR, and this could be one of the potential mechanisms how the benefits of reducing MR in these patients is achieved. As you know, this is the TEER procedure is a transvenous transeptal procedure in which a guide is placed after transeptal puncture in the left atrium, and then a TEER device, in this instance the mitral clip, is navigated through the mitral valve and then positioned in such a way that the two leaflets are positioned and are on top of the clip, and then the clip is placed, causing a tissue bridge, an edge-to-edge therapy, and this is why this procedure is called the M-TEER therapy. I think it is important to understand why are we doing a leaflet therapy despite the fact that the mechanism of MR in these patients is annular dilatation. And the reason why it works, although it's a leaflet therapy, is the fact that we do leaflet therapy, but we actually do is an indirect annuloplasty effect. By pulling on the leaflets, we ideally also reduce the annulus, and this adds to the reduction of MR. It adds to the efficacy of the procedure. So it's a leaflet therapy, but it provides an indirect annuloplasty effect, so it addresses the problem, which is annular dilatation. And as you can see also in that example, an image of pre-treatment on the left and then post-treatment with implantation of 2 Pascal devices in that patient. You see obviously a nice reduction of MR, but you can also see that there is annular reduction, as very often seen in these patients. We've heard already about the great benefits seen in the co-op trial. These are the Kaplan-Meier curves. What I also always like to show, because I find it very impressive, is the number needed to treat, also in comparison to other pharmacological studies in the field. And there we see in the co-op trial a number needed to treat of 6, which means that you have to treat 6 patients with MR to save 1 death. This is very impressive, and these numbers can also be used when consenting patients. And given all the benefits and the very solid body of evidence, it now received a Class 1A recommendations in the very recent valve guidelines. The question which remains a little bit is the timing of treatment, and there is a clear recommendation, and there's no doubt that medical therapy comes first and is of utmost importance. So GDMT should be optimized, and we also do have some evidence that in a certain proportion of patients, after optimizing GDMT, MR can actually be reduced and might not be relevant anymore as long as GDMT uptitration is successful. So the current approach at many sites, at many centers, and for many treating physicians is to wait at least 3 months and have several attempts of GDMT optimization. But we also know from Reshape that the Kaplan-Meier curves diverted very early on. And we also have learned from STRONG-HF that a very rigid and clear protocol of GDMT optimization can actually reduce endpoints very early on. So it seems that these patients are at risk very early on, and therapy needs to be early and as successful as possible. So you have to hit hard and early. How often are we successful in GDMT optimization in patients who undergo the M-TEER procedure? And we have to say that almost none of these patients are at really optimal GDMT. If you consider a GDMT score optimal to be 8 or greater, we can see the distribution of GDMT scores in a real-world scenario of patients who undergo M-TEER with HFrEF and FMR. And sometimes it's thought that we don't try hard enough to optimize GDMT in these patients. But it's probably much more true that the reason why they aren't under optimized GDMT is because it's very difficult to do so. These patients, and also Julie demonstrated that very nicely in her case, they have very often low blood pressure, they have very often impaired renal function. These are the obvious reasons why GDMT optimization is limited. But we also have some data which show that after treating MR, after an M-tier procedure, hemodynamics can be stabilized and also renal function can be stabilized. And we have seen in a large European registry that about 1/3 of patients experience GDMT optimization after treating MR. And those patients in whom GDMT can be optimized after treating MR, they have a better outcome than those in whom it is not possible. So I think it's very important that we move now away from the concept that on the one hand we have GDMT, on the other hand we have treating MR, and these are two different pathways. They belong to each other, they can facilitate to each other, and we are very well familiar with the concept that one drug therapy can enable a device therapy. We more and more are used to the fact that one drug therapy can allow a different drug therapy, and we discussed that briefly, like potassium binders and MRAs. But we now have to appreciate more that also device therapies can enable drug therapy, and I think this is very important, in particular for these subsets of patients. Thank you very much.
Thank you very much. Thank you very much, Philippe. I'd like to start this last bit of discussion just with you, Philippe. I've seen this hemodynamic curve of the case that Jolie just shown, and the dramatic improvement in hemodynamic right after the placement of the clip in this patient, which I guess facilitated the implementation of further therapy. Do I understand it well that if this patient would have come immediately to Mainz, to your center, you would have proposed M-tier as a first intention?
Well, maybe, yes. I think it's always fair to try to optimize medication. And if you do so, try it as best as possible, but make sure that follow-up is very closely. And you not tell the patient to come back in 3 or 6 months and see how it's doing, especially in those who are fragile. It's always worth to try it, but then make sure that you see the patients back very soon. And if you fail, then you should think about M-tier very early.
So, Michael, if we want to stretch a bit the reasoning that Philippe has just shared with us, can we consider M-tier as the 5th pillar of heart failure patient with reduced ejection fraction and MR?
Yeah, yeah, maybe, but it's not the 5th pillar, because the 4 pillars are for a non-selected population without any inclusion, and this is for the subgroup with MI, which is not applying to the 1st pillar, the 4 drugs, because then there is usually no entry criterion. So it will be stay in the 2nd line. But what I'm completely agreeing is that it shouldn't be done too late. What has also been done, we always talk about blood pressure when we talk about stabilization, but Jolie has very nicely shown a drop in central venous pressure and unloading the kidney. So there is also good reason to do these unloading, not only of the heart, but also on the kidney. So I think there is another point which is important. 5th pillar for selected patients. Formally in the guidelines, it would not be in the 1st line.
Why did the ejection fraction stay at 20%?
Because there is end-stage remodeling, a lot of fibrosis. Maybe there is something which the slippage of the ventricle is already end stage, but still the patient might benefit.
Now, okay,
the problem is to predict this. What I would suggest is looking at fibrosis as we are doing with sudden deaths. That is something which might be a future avenue to look at.
That's a good point. Stefan, to you. We learned in the initial discussion that amongst the factors that prevented GDMT optimization beyond the hypotension, there was hyperkalemia. Amina already alluded to that. Is it really hyperkalemia a red flag to optimize medical therapy, or is there something going on in development that could address this issue in the near future?
Well, I mean, it is kidney function in the end, we have to be honest. And potassium binders are of course, acting on the symptom of poor kidney function. I think really improving kidney function is, of course, something that we want. And I think Philip is right, earlier treatment. But that's not only true for devices, it's probably also true for the drugs and as early as possible kidney protection for these patients, really seeing them not only from a perspective of heart failure, but of cardiorenal metabolic disease. When they're obese, well, take care of the obesity. When they have maybe iron deficiency, take care of the iron deficiency. Really also, of course, try to specifically improve kidney function if you can. And I would, yeah, this needs more. This patient clearly needs still some more treatment. And as I just tried to say, maybe this patient is now perfect to go into the next trial with omecamtiv mecarbil for really trying to see to improve the cardiac function directly.
Questions?
Okay. Yes, we have one question coming up from the chat and bringing up another topic, that's AFib. So if a patient comes with AFib, usually your patient was in sinus rhythm, what comes first, atrial fibrillation or MTIR? So I would like to ask this question to the panel. Who wants to reply to that?
That is a typical topic of a lot of pro and con discussions. It depends on who you're asking, right? So the heart failure specialist and the interventionist would say MTIR. Some people from the arrhythmia field would say it's atrial fibrillation. I think in the majority of patients it would be MTIR because that is clear. It is indeed a volume overload of the ventricle. And we've seen some improvements, but if the ventricle is remodeled already to a significant amount and the dilatation of the ring, then I doubt a little bit that in the majority of patients, obviously, there is a significant improvement by avoiding atrial fibrillation.
Thank you. While we are heading towards the end of this session, let's try to collect some final thoughts from our colleagues. Amina, any final considerations around this case and these discussions on your side?
Yes, Emanuele, I would also like to state a little bit more about hyperkalemia. I would also like our colleagues that are listening to this session just to keep in mind that actually hyperkalemia is not only it's also an independent risk factor for worse prognosis in a heart failure, because patient who really develops hyperkalemia often have more advanced heart failure, kidney dysfunction, as already Stefan stated, and also neurohormonal activation. And that's why it's really associated with a high mortality and more hospitalization. So we should not afraid of hyperkalemia, but we should really think and really try to to normalize potassium level, especially if we have a potassium binders for our patients for the treatment and optimization of a GDMT. So this is from my side.
Thank you.
Okay.
Still question.
Just another question coming up from the chat. And you told me to pose it to
Yeah,
Stefan
because
Anker.
he alluded to the topic, so he needs to address it.
So how aggressive you recommend going with obesity management, GLP-1 or even surgery referral?
Well, of course, in heart failure with a reduced ejection fraction, we don't have the trial evidence yet. If this patient is diabetic, then you can use the diabetes results, but you should really be careful with GLP-1s in the setting of HFrEF. There is hints from observational research that maybe not in every case you do good with this treatment. Within limits, I would actually promote the idea of losing, if the patient has a BMI of, let's say, 35, 40, get rid of some of the weight. The life of this patient will be lighter.
That's very well said. Julie, how is the patient doing, by the way? Do you still follow the patient up, or did you send the patient back to his initial hospital?
Is still in our hospital, and for this patient, actually, we try to combine the the follow-up with the referent cardiologist that can do visits in close time, and once in a 3 months or 6 months, the patient come to the university hospital to still evaluate it if we are going in the pathway of the advanced heart failure therapy.
Thank you very much. Philippe, any final comments and considerations on your side before we close the session?
Yeah, maybe I would like to make two very specific comments and then one final remark. One comment about the hemodynamic improvement. If you're in doubt whether M-TEER really improves hemodynamics, it's something which happens immediately after closing the device. It actually is something we use during the procedure to judge success. We would like to see an increase in blood pressure. Very often we see an increase in 10 millimeters of mercury, and then we know, in addition to the echocardiographic assessment, that we have done it right. And as said, the hemodynamic improvement comes immediately after reducing MR. The comment about AFib in atrial FMR, it might be a slightly different story, because there converting a patient into sinus rhythm can actually reduce MR. The only problem, both in atrial and ventricular FMR, is that normally the left atrium is already remodeled and the success of ablation might be limited. And overall, I would like to stress once again that if you think about M-TEER, it's not just a treatment to reduce MR, but it's also a way to optimize GDMT.
Sabine.
So thank you. This was almost a great summary of the session, and I would like to thank everybody for the great discussions, also the audience. And I would like to summarize the key learnings we had in patients with HFrEF and mitral regurgitation. GDMT optimization seems quite challenging. And we have seen in a case that MR reduction with M-TEER is associated with really improved clinical outcomes by enabling uptitration and maximization of the GDMT. And if we should apply M-TEER earlier in the history of these patients, that means at an earlier stage with less than severe mitral regurgitation, this is a topic that deserves further and future investigation. And I would like to thank everybody for joining us, and we would be very happy if you would join us tomorrow again from 8:30 with the first session, which is about integrated care in aortic stenosis and HFrEF, from medical therapy to percutaneous intervention. Thank you very much.
Thank you very much.
Thank you.
Thank you.